Hello, Jatinder.
Good evening, ma'am.
Yeah, right.
Yeah. Yeah. A very good evening to one and all of you for this very interesting learning webinar on an update of retina on behalf of ARC on OCT and OCTA. And we are truly enlightened to have a great set of expert panel here. Leading them is our President Aios, Dr. Lalit Verma, who's going to bring in just that kind of energy which this webinar needs, along with all the leading stalwarts who are here along with him. One of the leaders of the CFS group of hospital, he mans the retina department there along with his associates therein. And having had one of the largest stints in the various posts of AIO's office and uncountable awards and accolades, I'm sure we have to make the best of his presence with us. It's unfortunate that Dr. Unnikrishnan Nair, who was to be one of the panel, is not with us, but I would still introduce him all the same. He's the medical director and senior consultant vitreoretina services and neuro-ophthalmology and electro-diagnostics from the Chaitanya group of hospitals. We have with us a young dynamic surgeon, Dr. Mudit Tyagi, who heads the vitreoretina unit at the LV Prasad Institute at Hyderabad and is a specialist in vitreoretinal diseases, uveitis and immunology. And we really look forward to his active, energetic participation. We have with us joining soon Dr. Jay Chablani, who is the Associate Professor of Ophthalmology from the University of Pittsburgh School of Medicine. Again, a very dynamic young vitreoretinal specialist from there. Joining us soon would be again Dr. Ritesh Narula, who's a consultant ophthalmologist and specialist in vitreoretinal diseases from LV Prasad Institute, Hyderabad. He has not yet joined in. And we are lucky to have another very dynamic, absolutely driven Dr. Aniruddha Agarwal, who's the associate physician, retina and uveitis at the Eye Institute of Cleveland Clinic, Abu Dhabi. And as always, I feel as if I have an army behind me when we have Dr. Muralidhar as an expert panel. He's a past president of the Karnataka Ophthalmic Society, who heads the Retina Institute of Karnataka, based in Bangalore, and with over 3 decades of experience. He's one of India's leading retinal specialists and the senior most retinal specialist from Karnataka. Moderating with me are 2 dynamic individuals. One is our own Dr. Srinivas Joshi, who is the director of one of the directors of MM Joshi Group of Hospitals with keen interest in research and community services. Again, a very versatile surgeon, and is also member ARC South and is a big strength for our ARC team. With us today, moderating along with us is Dr. Jatinder Singh, who is a senior consultant vitreoretinal services in UVA at the Eye Foundation Group of Hospitals, and we hold him in very high respect for the amount of knowledge fountain which he carries along with him. And we shall now, with the strength of this great set of expert panel, we shall now go on to our first speaker, and who's none other than Dr. Padmaja Kumari, who's the network head, the teleophthalmology, and also senior consultant vitreoretinal services at LV Prasad Institute, Hyderabad. And she is going to tell us on something so important, NFAS OCT, does it add value? So on to you, Dr. Padmaja.
Okay. Good evening, everyone. Are my slides visible?
Yeah.
Okay. So at the outset, I would like to thank Dr. Chitra and ARC and AOS team for giving this wonderful opportunity and for conceiving a very important topic. So NFAS OCT, does it add value? This is my topic. So what is NFAS OCT? It combines OCT with transverse confocal analysis. So it gives us a transverse retinal and choroidal images at a specified depth. So what is its advantage is that it gives you microstructural and morphological changes seen in a coronal view. And it can be layer-wise, the extent of pathology can be mapped and precise measurements can be done. And most important, it provides a view similar to fundus photography. So when I was collecting all the images for this topic, I realized that this is something like a life that is given to optical biopsy. It is a light that is given to optical biopsy of histological section of retinal layers that are seen on a conventional OCT scan. So here you can see an example of Ritesh et al. They presented the case report of a tigrade pattern on hypotonic maculopathy. You can see beautifully an NFAS image, the choroidal folds that can be seen very clearly, and one can understand immediately the pathogenesis and as well as the layer involvement. Another prominent finding that you actually look for on NFAS OCT is we'll look at some case scenario. One important thing is a dissociated optic nerve fiber layer, downfall. So on NFAS OCT, it will be seen as a concentric macular dark spots, which will help us to know quantitative evaluation of this downfall. So Steele et al. Actually compared the type of ILM peeling with the diamond rust scratcher versus regular forceps, ILM forceps peel. And they found that probably with the diamond scratcher, probably you will have these downfall effects will be more. And you can see here an example of a downfall seen at the 1 month post-evaluation. And here you can see a case of downfall which is occurring corresponding to the ILM peeling. So, and what is its importance is that whenever as a surgeon, when you are doing different techniques of macular hole, which could be a flower petal or cabbage peel or onion peel, variety of techniques, it will also help you to evaluate your own surgical technique. So recently I started doing this flower petal technique and I was trying to see how is the NFAS OCT, is it showing any downfall effect? Some of these initial ones will disappear, but it will help you to evaluate your surgical technique as well. And here is another example of NFAS OCT showing an OCT section of a high myopic with a foveal chassis, which is seen only only on the nasal side. So, for example, in this case, if there is a progression is there and probably an ILM peeling, how much extent you can do, also probably you will be able to get a clue by using the NFAS OCT. And here is an example of epiretinal membrane. One can see all the tentacles and everything surface, which you can see very well on NFAS OCT. So you'll be able to know the structural and extent and the depth of the pathology. And here we don't really anymore require a FFA late phase to know the flower petal appearance of CME pattern seen on NFAS OCT in the macular edema. So NFAS OCT non-invasively, one can detect these changes. And Zheng et al., they have found that in venous occlusions, they found on NFAS OCT seeing a macrophage-like cells, which are seen as hyperreflective deposits. They're more commonly observed in acute phase of venous occlusion. So here I was just seeing this case in the clinic last week, and I observed that these actually in an old occlusion with a degenerative cyst and all, these hyperreflective deposits will be not seen as much as what you see in acute occlusion. So one will be able to know the acute versus chronic nature as well as being based on the NFAS OCT. And one can actually also map the PAM lesions very accurately on NFAS with a characteristic opacities as well as the periveneal deposition. And one can actually exactly know the extent of the involvement of this PAM along with the cilioretinal artery occlusion in this article by Raz et al. So one can see very clearly quantitatively mapped. So it will give you both quantitative value as well as the qualitative value. And in case of AMD, it helps us to quantify the geographic atrophy. In case of CNVMs, we will know the extent of the progression and extent of the involvement. And also, this is a case of old pruned network, and one can see the extent of the progression and underlying damage, layer-wise layer, and photoreceptor integrity. And this is another case where you will be able to know beautifully is cases like central serous retinopathy. Here you can see that the NFAS OCT is showing you the PED and everything changes, and the hyperreflective dots can be seen in the choroidal phase also. So one will be able to know layer-wise layer, whether it is an acute type, simple type of CSR or a complex of type CSR using this imaging modality. This is again another case of complex central CSR where you can see very clearly NFAS OCT showing the gravitational tract. So one will be able to know whether it is a simple CSR we are dealing or a complex. And this is again in a follow-up period. Also, say a complex CSR, when you use an NFAS OCT, you can see at the ISOS junction level the kind of changes that you're seeing. And also one can quantitatively and qualitatively see in the follow-up periods whether the changes, how things are happening. And another interesting area where one can use NFAS OCT is in retinal degenerations like Stargardt's. So here in this article by Sodi et al., they have clearly shown, they compared fundus autofluorescence with the NFAS. So this is an example where fundus autofluorescence was showing some amount of hyperreflective changes, whereas in NFAS OCT at the level of the photoreceptor layer, there was no change that was detected. So this is a patient which is not showing at the degeneration at the level of photoreceptor. Similarly, a case of advanced atrophy where you can see the changes in the very clearly on the NFAS. And they also compared the both photoreceptor slab as well as sub-RP slab and sub-RP slab and photoreceptor slab. And they clearly concluded that the Stargardt's disease, the photoreceptor layer degeneration, those changes are much more common compared to compared to the RP layer, telling that probably the disease starts at the photoreceptor degeneration going on to RP atrophy. So it will also give us insights into the pathogenesis. This is again cases of hydroxychloroquine retinopathy, where Hedge et al., they've clearly shown that the NFAS OCT at the baseline did not show any much changes, but at 2 years follow-up, this patient was showing, due to chloroquine toxicity, in FAF, we could not clearly see the actual extent of the damage, but in NFAS OCT, one can see a clear circumferential area of showing the photoreceptor disintegration and showing the early toxicity. To summarize, NFAS OCT is a useful investigation. It adds life to your optical biopsies shown by the OCT. It is acquired during conventional OCTA scan on the same machine. View is similar to fundus photographs, so easier to understand the disease and also interpret the findings to assess the disease prognosis better than the conventional longitudinal OCT scan. So, and disease-specific correlation, that is structural changes in NFAS OCT with the functional changes like FAF and clinical changes, there will be a definitely potential to reduce the need for additional invasive investigations. And definitely future is to look for NFAS OCT findings based guidelines to map disease progression and prognosticate. Thank you for the opportunity.
Dr. Srinivas, wonderful talk, Dr. Padmaja. It was so good. Could we have Dr. Srinivas and taking the first question, and then Jatinder?
Padmaja madam, wonderful talk as always. So would you prefer always using an NFAS with the FA or with the IR? Or is it by default an IR, and in select cases you order for FA, or you order both IR as well as FA on the NFAS?
You are mentioning autofluorescence, right?
Yeah, autofluorescence.
Yeah.
Fundus autofluorescence.
I think it's good to correlate with autofluorescence in diseases like retinal degenerations and dystrophies. But otherwise, in a regular like vascular disease and all, IR should be enough. And but what I feel is more just comparison of your OCT itself with NFAS value. I think along with the fundus photograph and the clinical features in mind, it really adds a dimension to your thought process.
Jatinder, sir?
Jatinder?
Dr. Padmaja,
And very warm welcome, Satyajit. Unmute yourself.
Thank you, ma'am. Thank you, ma'am. Good to see you back from Africa.
Yes, yes, Dr. Jatinder.
Dr. Padmaja, I have one query. I mean, what do you think are the limitations if it is so good as you have mentioned in your slides, and they were excellent pictures that you have actually described and very well demonstrated. But what do you think are the limitations? Why is it this not generally acceptable? Is it just mind block, or people are not explored this as an option? Or do you think there are certain limitations that would actually be of concern?
I think limitations will go on for as with the Oct learning curve, and then taking correct segmentation. Probably that is the most important layer, and probably NFAS OCT will definitely, whenever we order these investigations, we should definitely look at what layer the image is going, and then also the artifacts that comes with Oct. One should be able to be very careful. And why it has not really gained the interest is probably, I think, awareness and mind block. Otherwise, I think it adds beautiful value. In fact, Ritesh recently joined us, and we are going to change all our image protocols into NFAS Oct to see in the report, because once it comes as a report and we start reading, and we'll be interpreting much more.
Dr. Aniruddha, you wanted to tell something?
Can I make one point? I think NFAS imaging, especially if you're operating epiretinal membranes, it becomes really important because you can use your NFAS imaging and scan your deep retinal layers and see the level of wrinkling of the outer retina. And you can actually prognosticate these patients very well. Sometimes if you have photoreceptor wrinkling on the NFAS imaging, you know that these patients may not visually benefit so much. Whereas if the ERM is limited only to the superficial layers, those patients can have a better outcome. So I think NFAS is really catching up.
And I think NFAS OCT also should be part of any surgeon who does these macular surgeries, even as a post-op follow-up of your own technique to understand how much the tissue damage is happening.
Thank you very much, Dr. Padmaja. Srinivas, would you introduce our next speaker?
Okay, so we'll move on to our next speaker. A young VR surgeon, always smiling, Dr. Dhwani Shah from the prestigious Prabha Eye Clinic and Research Center from Bangalore. And so today, Dhwani will be speaking on the quantitative evaluation of OCT features, the utility and the pitfalls. Over to Dhwani.
Good evening, everyone. Thank you, Aios, Chitra ma'am, for giving me this opportunity to present in this forum. The OCT first was developed, the technology and the concept was developed by Dr. David Huang et al. Under the guidance of Dr. James Fujimoto at MIT. Humphrey Instruments launched the first commercial OCT in the 1996. From the early 90s to now, the resolution has improved drastically. The quantitative 3D analysis of the retinal layers and the volumetric analysis of the retinal and deeper lesions is now possible. The volumetric OCT image gives the retinal layers coinciding with the specific cellular layers. Small sensitive measurements of the optic nerve, the retina, the choroid is now possible for chronic diseases like glaucoma, AMD, DME, etc. The 3D macular protocol is used for the macular thickness measurements. It consists of a raster scan that is taken over the cube over the macula. False color or a gray scale topographic image is then reconstructed. Macula is divided into 9 regions with 3 rings concentric around the foveal center, that is 1 mm, 3 mm, and 6 mm, according to the ETRS map. Automated analysis is derived from the variations and deviations from the normal values. Volume scan, a smaller cube will cover around 20 degrees of the retinal area, a wider cube will cover around 40 degrees of the retinal area. All commercially available OCT today will have several quantitative and automated measures. Most commonly available and used is the RNSS thickness for glaucoma and the total retinal thickness. Manual caliper function can measure the size of a macular hole and makes many such distance-based measurements. Coming to few common conditions, I'll talk about neovascular AMD first. Qualitative versus quantitative assessment have a lot of discrepancies. However, recent advances in deep learning have stipulated upsurge of automatic assessments within the OCT volume like the IRF, the SRF, the PED, the SHREM. The retina in the advanced neovascular AMD has 3 important fluid components, the IRF, the SRF, and the sub-RP. And the accumulation of the retinal fluid is a hallmark of disease activity. Quantitative measurements of these fluid spaces can be extracted efficiently by artificial intelligence algorithms. It identifies the fluid characteristics at baseline and during follow-up. It is very useful for clinical practice and research. Analysis of the fluid with artificial intelligence can revolutionize the retinal diagnostic techniques. Now, measuring the fluid in 3D space, we have manual versus automated, which is almost similar to each other. Hence, it will help for future diagnostic evaluation. So quantification of fluid is important as lower level of any fluid is associated with better visual outcomes. IRF, whether recurrent, residual, SRS, and PEDs are associated with progressive vision loss. Quantification of CST is important as a stable central foveal thickness is associated with better visual outcomes. Management based on the response to treatment can be planned. Coming to a case example, I have an 82-year-old gentleman who complains of decreased vision in the right eye since 3 months. Left eye is essentially okay. The right eye has a vision of 6/12 N10, and the fundus is showing subretinal hemorrhage, exudation, PED, suggestive of PCV. This is the baseline OCT on presentation, where I have given an anti-VEGF injection. And I have serially monitored the response. And we can see how with the treatment, it has beautifully resolving. Coming to the quantitative analysis of OCT features in DME, After the advent of anti-VEGF therapy for centers involving DME, central subfield thickness is become very important. OCT helps in quantification of the retinal thickness, mapping of the area of thickening, location of fluid, presence of VMT and ERM. Evaluation of foveal microstructure and retinal layers is an indicator of visual recovery after treatment. Coming to a case example, I have a 72-year-old gentleman who is a diabetic since 40 years. His vision is 6/12 parts. OCT on qualitative examination is showing a CME and a spongy edema. Thickness map shows this red-colored areas of retinal thickening. Hence, he's received anti-VEGF therapy. Post 2 months, we see that the vision has improved to 6/6 parts and the cystoid space is still persisting. However, the areas of retinal thickening, the red areas on the map, has resolved. Post 6 months treatment, he is still stable. However, 12 months post-treatment, we see that the swelling has come back. He's developed an ERM and a spongy edema. The thickness map also shows corresponding changes. Coming to the features of the choroid. Choroid is an intricate vascular network. Alterations in the choroid's anatomy can lead to functional impairments affecting itself and the retina. It is important in the macular diseases like AMD, CSR, posterior uveitis, which can compromise central vision. Recently, a new biomarker, the choroidal vascularity index, is developed. It analyzes the choroidal vasculature and the choroidal thickness is captured on the OCT-B scans and choriocapillaris layers of the OCT-A. It helps in understanding the choroid's vascular status and quantification of the stroma, enabling the analysis of different choroidal components. However, applicability of the CVI data in general population still awaits further validation. Manual measurement is what we do commonly with the built-in caliper. However, it does not represent the choroid's complex vascular architecture. Any fluctuations in thickness could be due to the alterations in stroma or the vasculature. Qualitative analysis of the choroid is reliable and we use it. However, quantitative parameter produces repeatable results and creates a common language for clinicians and researchers all across. A case example, I have a 32-year-old lady who's coming with decreased vision in the right eye with pain. Fundus examination shows a large choroidal lesion with subretinal fluid. Entire workup of uveitis was done and she has responded well to steroids and ATP. This is my timeline from presentation to resolution. You can see that there's a large choroidal nodule near the superior arcade, which has resolved very well with treatment. Coming to a few pitfalls, we have manual measurement can cause considerable inter-observer variability. Incorrect segmentation will result in abnormal retinal thickness measurement by incorrectly identifying the inner and the outer retinal boundaries. Thickness measurement may not correlate with visual acuity and vision progresses always. Coming to a case example, I have a 72-year-old lady who's come with decreased vision in the right eye since many months. She's a diabetic and a hypertensive and the vision is 2 meters. She has NPDR, status post grid laser. This is the OCT where it's showing a patchy ERM and a cystoid macular edema. She has received a dexamethasone implant. 2 months post-treatment, vision is still CF 2 meters. We can understand that the OCT is showing some drill, the hyperreflective spots, Aios irregularity. When she has recurred and the OCT has CME, at this time, I'm not going to plan any aggressive treatment. We have some artifacts like the mirror artifact, which is a partial or completely inverted image. It is more common in high myopes or when the focus is too near to the eye. Misalignment due to poor or eccentric fixation of the patient. We have a cut-edge artifact signaling that the iris blocking the OCT beam. A surface irregularity will result in poor image, a blink artifact. Poor quality of the images due to cataract and vitreous hemorrhage will lead to unsatisfactory automated segmentation. Hence, qualitative evaluation has to be done. Machine-to-machine variation, because there is no standardized limit for the automatic determination of retinal thickness. For follow-up, it is better to use the same device platform. So to conclude, I have a few points to make. Slit lamp examination, of course, essential, but OCT is more sensitive to detect small changes. Quantitative imaging is repeatable and non-invasive, hence ideal for monitoring. Helps in evaluating the natural course of disease, severity, follow-up, and response to therapy. Appropriate acquisition technique is really necessary. Understanding the machine's capabilities helps. Artificial intelligence has the potential to revolutionize the retinal diagnostics with techniques that may help optimize the disease management. Thank you all for giving me this opportunity.
Thank you, Dr. Dwani. That was again another very amazing talk. So let's go on to the discussion. Srinivas.
Yes, madam. I think good talk, Dhwani. Wonderful. You have
Thank you.
just told us the important points. I would like to pose this question to Dr. Anirudh. Due to some emergencies, I think medical ME is leaving now in another 15 minutes. So I just would like to ask him the question. Dr. Anirudh, are you there? Or he already
Yes,
left?
I'm here. I'm here.
Okay. So as Dhwani explained, now we all know that the volumetric scans, the kind of, it's not just the SRF or the IRF, which is now being discussed. It's the PED volume at the baseline, the height of the PED, and also the CVH, that is the choroidal vascular hyperpermeability, choroidal vascular indices, that is all coming into the picture. What is your take on all these things, using these new volumetric indices in managing? I do agree, because sometimes when we see, when we are looking at the brolucizumab response in case of the height of the PED, when we see there's a drastic reduction in the height of the PED, but that does not mean that it's actually the flattening, but the volume of that PED might still be large enough. And they say that these are the CVI, the CVH always indicates the disease activity. And that is where the treatment regimen changes from PRN to treat and extend the kind of things on these kind of diseases. So what is your take on this?
So I think, sir, you have made excellent points that there is a lot of stress now on volumetric analysis and anatomical response to especially new agents like brolucizumab, and now we have faricimab coming, who have been shown to have probably a better anatomical and volume response on the volumetric analysis. But I think beyond the quantitative measurements, we also have to look at the morphology of the lesions itself, and whether flattening a PED or making the retina thinner or the choroid thinner makes really a difference in the visual outcome. So at some point you have to say that there are limitations to this analysis, and you can only use them to a certain extent. But beyond, I think, especially if you have 2D analysis, like CVI, for example, has taken a back seat since the time volumetric analysis has come. So there are some analysis now which are being done, especially, for example, in diabetic eyes, where we do the phase area, which may have a relevance today. But for example, you have eccentricity analysis, you have acircularity indices. These geometric measurements may not always be relevant in clinical practice. So they are good research tools, but may not be always clinically relevant.
Fantastic. Thank you.
Dr. Jatinder?
Excellent
You
point.
take questions with including all our expert panel in different set of discussions.
So excellent points, Anirudh. I think giving the time that we have, time constraint that we have in the clinic, going through each and every scan is going to be difficult. So once we have the AI and volumetric assessment done by the AI system, I think that will ease out, and we'll probably would not have to go and look into each and every detail of every scan throughout the zone that has been scanned. Ritesh, do you have any inputs on this subject? Volumetric analysis, how often do you use it, and what do you find is the relevance of it?
I just want to add one thing what Jatinder sir said. And do you also know any of these softwares where it is commercially available, where we can use it, or a third-party softwares where we can use this volumetric for this volumetric analysis? Ritesh bhai?
Yeah. So two parts to the question. Actually, two parts of the disease. With DME, we are all using quantitative and volumetric scans. So that's not something which is unfamiliar with us. We are already using it in terms of thickness maps, in terms of retinal thickness maps. We are already using it, and most of us are looking at that. In terms of AMD and specifically looking at choroid, one of the biggest challenges with all these volumetric analysis is we do not yet have normative data. So we are going to be comparing a disease from a normal. We don't have age-specific normative data to be able to analyze it. None of the machines as of now are doing it automatically. We need to use third-party softwares like an ImageJ software, which you use to segment these images into choroid, different parameters, the choroid from the inner retina. You separate them out on ImageJ and then do these analysis on them. So yes, as Dr. Jatinder is rightly saying, it's not possible to do all of these when you're doing a clinical work sitting in your clinic. It's a great research tool as of now. Till the time AI comes in, till the time they get incorporated directly into the machine softwares, probably we are not going to be using them to that much extent clinically. Eventually, once these all parameters come, more studies happen on that. We'll see how it comes out and how relevant each of these parameters turn out to be then.
Great.
Just one last one point. Do you think the little bit of the eccentricity of centration as compared to the previous scans that can be actually taken care of by doing this volumetric assessment? Would that be a benefit? I mean, if you
It will
have,
be a
it is something like you're doing a slab and assessing the entire volume rather than just looking into one scan and measuring the dimensions. This is what is being done in the clinic most of the times. But if you have an entire volumetric assessment, so shifting of fluid from one zone to the other zone would be actually, whether it is because of the eccentric scan or whether it is really an increase or decrease in the fluid, would that be a guide?
Absolutely, Dr. Jitendra. I totally agree with you because it gives you that second dimension. So this talk and the NFAS talk actually is giving you that third dimension to looking at an image where you're looking the image front on rather than just looking at a cut section. So you're looking at an image in the third dimension. You're looking at it in terms of volume and the face. Both add to your knowledge. And definitely, we have seen even in diabetics, we have seen the edema shrinks in volume, but the height doesn't decrease at the same time. So it does really help there.
Thank you very much. We shall now go on to our next speaker, Dr. Vatsal Parik, who's again a very prolific vitreoretina surgeon from Mumbai, and he heads the Drishti Eye and Retina Center and Rajvi Nursing Home. So look forward to hearing a lot from him. On to you, Dr. Vatsal.
Yeah. Good evening, Dr. Chitra and respected panelists. Can you hear me?
We need to see your screen too.
Yeah. One. Just one. Are you able to see the screen?
Yes.
One. Can you hear me also, please?
Yes.
Can you hear me?
Yeah. We are able to hear you. You can go ahead, sir.
So, please. Good evening. Today, I'm going to share my experience with this machine which we have acquired 2 years back. That is image-guided ultraviolet field swept source OCT, its clinical applications, and what I feel it could be the future and how it could be helpful in future to come. Now, I do not have any financial interest in this machine, nor any of the presentation what I'm showing. It's basically a multimodal imaging with ultra-wide field view. That's about 200-degree and single view. And it's a swept source ultra-wide field OCT. You can do probably anywhere in the retina up to equator and beyond equator sometimes. And I feel it's an useful adjunct in retinal armamentarium. I'm going to show you some of the patients where we find it to be useful. Now, this is a macular hole which is about 1000 microns. I did vitrectomy with ILM stuffing and SF6 gas. This is 3 hours post-op. You can see that probably the hole is getting close. But 1 day post-op, we could definitely see the hole through the eyes gas fill. OCT was of good quality. And 1 week later, when the gas bubble has gone above the macula, you can see that the hole is closed. So I think this should help us in monitoring the post-op positioning of the patient, especially when you can do OCT through the gas bubble. Now, this is a patient who had lattice degeneration. As you see here, we could do OCT through the lattice. Normally, we read in textbook that lattice shows retinal thinning, which we see very often in our patients. But this patient had retinoschisis-like appearance, though he had lattice degeneration. This is a white without pressure picture, and OCT shown through that area shows schisis-like picture through the white without pressure. Now, this is an interesting patient. His father, he's a young boy who is high myopic. Both had giant retinal tear operated by me. On family screening, it looked like a horseshoe tear here. But we were fortunate that we could do OCT through this particular thing at ora serrata, and it shows an enclosed dentate process, and we have reported this case in a journal. Now, this patient had post-vitrectomy detachment, and You can see on ultra wide field photography that there are retinal holes, and OCT done through that area, as you see, confirms the hole. The beauty of this machine, I think, is compared to indirect ophthalmoscopy or slit lamp biomicroscopy, this machine gives better contrast image, so holes can be identified easily, and we are fortunate to able to do OCT through that. So I did cryopaxy and topped up the gas by putting additional C3F8 injection and gave prone position to the patient. The retina settled. However, after 5 days, there was a redetachment which was increasing, and though clinically the photograph doesn't show PVR, I thought this was related to PVR process. And serial photography showed that there was peak fold appearing. At this juncture, clinically, I thought that the membrane is mature and we could do OCT through that area, and it showed the age of the membrane. And it helped us in operating this patient, and post of the retina is nicely attached and there's silicone oil in the eye. Similarly, OCT done through the macula progressively showed that these are corrugated folds because of the hydration line, and a smooth counter is gone because of the ERM. And on OCT, we could determine where the ERM was, and that helped in operating. And once the retina settles, the corrugated appearance disappears, and probably this being swept, so OCT will be able to assess the nature of external limiting zone at EL and monitor visual acuity. We have found it to be useful in retinitis patient also. This is a patient of toxoplasma retinitis, and you can see that there is a retinal involvement here, and with treatment, the retinal involvement is becoming less. However, this is also apparent on clinical examination, so this would be a useful adjunct for the treatment. But this patient, there was a whitish lesion here, and when you see OCT done through that area, it shows that mainly it's the vitreous haze and there's little amount of retinitis. So I think it has a role in uveitis patient also. Similarly, this is a patient of scleritis. You can see that this area is elevated. There was a T sign, and we treated this patient, and the contour came to normal. An interesting observation was in disease that you can see this is a crystal clump here. OCT done through that area showed abnormal vitreoretinal adhesions. So I think this will help us to uncover pathology which we are not seeing till now. I believe this has a role in measuring choroidal thickness and retinal thickness, starting from optic disc to the periphery. And as you see in this photograph, the thickness keep on decreasing, and we should be able to work this in different age groups and different refractive status. And this being swept, so quality, good image. Now, this was a patient with amelanotic nevus here, and you can see that the OCT done through that area shows the picture. You can probably have a role of this in tumors, probably up to equator. You can do the OCT. It showed hyperfluorescence. ICG showed again hyperfluorescence here, and FFA showed mild staining in this region. Now, this patient has a macular hole and a peripheral retinal tear. Now, clinically, we had missed this tear because, as I told you, that contrast is more with this machine. So, diagnosing tear was easier on the photograph. Clinically, it was missed, and OCT done through the tear shows that there is a also tear here. Now, this patient had RP with macular hole and normal vitreous pathology here. I did vitrectomy. The RP macular hole is settled after 15-20 days. You can see that the same area, the hole has closed. I left this vitreous here because there was strong adhesions here, and post-op you can see that this vitreous is getting detached. So I think this would show us more about vitreoretinal anatomy. Now this could be better than intraoperative OCT. This is a patient of PDR which I'm going to operate this the OCT through this region, where you can see the abnormal vitreoretinal adhesion here. To this region, you can see that there is a more broad-based adhesion here, whereas here you can see that the adhesion is not. So there is a potential plane. Here again there is a potential plane. Here again over the macula, this region there is a lot of space here, and when you go superiorly, there is the macular area and there is a superior area. compared to intraoperative OCT, this big swept source, I think this would have better resolution and you can plan your surgery well in advance. So to conclude, I think swept source, since it's a swept source OCT, it has better penetration than spectral domain OCT. Advantage is that you can do the OCT anywhere to Twitter and also possible to do through gas filled eye. The color picture may not show much detail, but OCT does come well in majority of cases. So it will help us in understanding pathology of the disease process, what we were not seeing earlier. So this technology, I believe, uncovers the undiscovered retinal lesions and it will open up newer avenues of treatment because you are able to document things so well. Thank you for your patience.
That was a wonderful talk, Dr. Vatsan. You're truly wonderful. The colored photographs really made it appear so easy. I have a very basic question which I'm going to ask Mudit, and I should be allowed my ignorance. But the things like motion artifacts and some ciliary, papillary shadowing and all that, would not there be some challenge in getting this wide field fundus imaging?
So as far as the imaging, I'm sorry, yes. Sir, you were saying something, please go ahead.
Yeah. See, as far as this is a wide field photography, this is covering more than 200 degrees of the retina. So your eyelashes and eyelids would come in the view. So obviously for presentation, we have selected based off images, but there's a little learning curve and with that probably it can reduce a lot.
Okay. Yes, Dr. Mudit?
Yeah, the same point which sir was saying. Basically, as far as the imaging is concerned, even for this ultra wide field imaging, while Optos does allow us more than 200 degrees of visualization, the problem that sometimes happens is that the eyelashes tend to obscure the view. So you end up having a lot of these photographs where you see these inferior eyelashes or the superior ones. And what happens is that if it's a superior photograph, the ones which will be obscuring are the inferior eyelashes over there. So one of the ways is it basically the learning curve while you're taking those images. Sometimes you can use a tape to put upon the eyelashes so as to ensure that it does not come in the field of view. But it is predominantly more of a learning of how you're taking those images. But even with those eyelashes, even apart from that also, the field of view which you get in a lot of these images is pretty superlative. So that usually does help in uncovering and imaging a lot of pathologies, which we earlier were not imaging.
I think I agree with what Mudit sir said, but sir, taping we have tried it with our Daytona machine. The patients experience a lot of problem and they do not concentrate and they do not fix it because of the probably the dryness they develop very soon. So I think the technician should be taught how to just separate the eyelids. And I think that will come away with most of the eyelashes. But whatever said and done, I have still seen with the best of the technician, we still see some of the eyelashes and it's really worrisome. Vatsal sir, which machine is this? Is this the Optos, the Silverstone, or which machine you are using?
Silverstone machine. This is the Silverstone.
Yeah.
So it has the capacity of Sweatsource OCT. Okay. Coming on the eyelashes part, we have tried all this because we have this machine for more than 2 years now. I think dryness is most important, as Sriva said, when you are tapping the eyelids. But once when you take 3-4 pictures, probably patient gets used to it and it does not tend to close the eye. So probably he's much better. It's question of some learning curve, but it can be avoided almost 70% of time.
Dr. Barbara, you have to say something?
Yes, I would like to comment on wide field imaging. Well, first of all, just to compare machines, the Zeiss Clarus does not have this problem with the 12 and 6 o'clock eyelashes because the way of taking the picture is completely different. So it's not common to all wide field machines. And then I would like to add that the main advantages that I found in OCT wide field in the periphery as well as color pictures is not just to be able to see this lesion, but first of all, to archive the lesion because you see them and maybe at the follow-up, you don't really remember the details. And when you compare picture to pictures, it's much easier. And second is much easier to find the lesion through the picture instead of contact lenses, because the compliance of the patient is much higher. In pediatric cases, it's much easier. You can take pictures of the fundus even in 2 years old or 3 years old baby without using any sedation. That's marvelous. And in most of the cases, the OCT can see lesions that you cannot see with the fundus view. Small, shallow retinal detachments. It happens to me in quite a few patients. So I really think it adds more than our visualization with contact lens.
Dr. Jatinder, one brief question. We'll go on.
Dr. Barbara has already answered. I had a few comments to make.
I can add Chitra for a minute.
Yes.
Can I add Chitra?
Yes, yes.
I think what Dr. Barbara said, in fact, we are making a routine practice to take photographs of all patients, because as I told you, the contrast is better with this photograph. So many times we have seen that we have missed lesion clinically, and when you see the photograph, you see that there's a horseshoe tear or there's some lesion, and you go back and see patient again, and you will find the lesion there to be there. Like the last photograph of macular hole which I showed, nobody would expect horseshoe tear. And that patient had choroid tessellation. So when we took photograph as a routine, we realized. I think what point she drew was very important.
Yeah. So, Srinivas, would you introduce the next speaker? Dr.
Yes, ma'am. Yes.
Yeah.
I think next we have a prolific surgeon and who's also a pan-ophthalmologist, who is none other than Dr. Upsham Goel, sir, who is a specialist in cataract, refractive, and VR surgery. He is the director of TC Eye Center. Over to Dr. Upsham, sir, please.
Thank you, Shri. Just share my screen. Yeah. So hello, everyone. So we are looking at the OCT now, and along with the OCT, let's look at the role of OCT biomarkers. Because as we all know, that quantifiable medical science, which are what biomarkers are, have become of great relevance in all clinical practice and research. Because while OCT has given us a lot of good quality images, the value of what it is showing us needs to be really understood. Because right in the early days of OCT, because we were among the earliest people to acquire this technology in India, HD OCT, and there was so much data being thrown up, which we didn't really know what to do entirely do with it. So now just over to the simple the image. Okay, are my slides moving?
Yes.
Okay, fine. So we have the normal anatomy, which we correlate with the OCT anatomy, and we are looking at some of the biomarkers as to when to look at a patient's OCT, when to be able to tell him that, okay, we think that the prognosis may not be as good as we think.
So sorry to interrupt. Can you put it in slideshow mode?
I'll try that, but sometimes it doesn't move forward. Okay, I'll just try that. And now again, are my slides moving now?
Yeah.
Yes, they're moving?
Yes.
Okay. So one of the biomarkers is the central subfield thickness. So a lot of these, what we call as biomarkers, are actually pretty obvious. It's self-explanatory, I would say, because the fact that why is fluid there? Let's look at that. Why is fluid there? And what is the normal anatomy? So naturally, anything that disrupts the normal anatomy will obviously cause a damage to the visual pathway itself. So similarly, the central subfield thickness, and it can be because of the presence of fluid, where obviously the greater amount of fluid and the greater the fluctuations, this would be the outcomes. And CSFT value may be high in the presence of epiretinal membranes and other fibrotic kind of things. So it is not just fluid, it may be abnormal tissue, drusense, fibrous deposits, and so on. Now, risk factors for development of geographic atrophy after treatment with anti-VEGF include the presence of fluid. So that's something we have to understand, that all drugs or anti-VEGFs can finally lead to geographic atrophy. And it's kind of a problem, because if you don't treat, again, you'll end up with fibrosis and geographic atrophy. And if you treat, then the drug itself can cause damage. That's why it's most people like to treat and extend as the disease requires it. Approximately 38% of subjects in the CAT study developed geographic atrophy after 5 years, and of course there was some difference in the various drugs that were being used. And now, in case of geographic atrophy development, naturally at worst. Exactly, that's what I thought, man. That's what I was saying. That unfortunately, I don't know why I have to be this mode. So is that okay? Is that okay? Now the slides can move.
Yeah.
Okay. So in case of geographic atrophy development, the whole retina. So now, one of the speakers was talking about on-face versus cross-sectional. We not only do on-face and cross-sectional, we do OCT angiography for all our patients because we think that looking at the vessel is very, very important. But all patients have to have the on-face along with the cross-sectional. Why? Because it gives us almost a holistic picture. I don't even have to look at the volume data. I just have to look at the picture on-face and we see it on cross-section. And then we see, and in exactly this kind of condition where you have treated the patient for a long period of time and there's a geographic atrophy developing, all the retinal layers thin out, and therefore naturally a very thin central subfoveal thickness will also mean a significantly lower visual acuity. The intraretinal cysts are, I mean, of course, we know primarily there are two fluids that we'll be looking at: the intraretinal fluid as well as the subretinal fluid, and IRCs are the worst fluid to have. They can go away more easily, but they are the worst fluid to have because they normally would be associated. Why? Because there is a greater disruption of the anatomy of the retina itself. That's the basic issue. All the inner retinal fibers and all the inner retinal elements, they start getting more damaged because of the presence of the IRC. There may be different types. They could be oval, etc., or they could be more round, and they could be more square kind of a shape. And it could be because of exudation, and sometimes they can be because of the degeneration in the RP itself. The exudative cysts are active, are coming through active fluid exudation, and are larger in size, and they are more oval in shape. After several months of injection, if you still have IRF, then these kind of patients would have naturally a high risk of developing fibrosis and RP atrophy compared to the refractory SRFs. And the subretinal fluid is a hyperreflective fluid accumulation overlying the RP layers. And it resolves in response to anti-VEGF, though it may not respond as quickly to as IRF, but there's interestingly, maybe we don't know, it may actually lead to provide some degree of protection to the fibrotic changes that may occur after the fluids are gone. So it is believed, because there were many talks about how much fluid will we tolerate. So it's agreed that IRF is something, intraretinal fluid is something you will not tolerate, and subretinal fluid is something which, if it is really not going away, then you may leave it alone, because trying to remove that little element of fluid may actually cause more damage to because of mitochondrial apoptosis, which takes place with every VEGF. It may actually.
You need to mute yourselves. Yes, doctor.
Yeah. So and the pigment epithelial detachment is some RP fluid separation. We have already other speakers are talking about in greater detail on that. And again, PD itself per se, the most important thing is PD per se. I would love to treat the PD. I would love to see it go, and I would love to use that VEGF which can make it go. If in case they stay, and in case they are not responding, and the visual acuity is better in a patient, I would probably think of accepting that fluid. SRF located on top of a PD instead of on the edge. PD may not, it may show that the PD may not be vascularized and may respond poorly to therapy. Whereas once the SRF is on the side of the PDs, then that means they would normally respond pretty well. Now, a very important thing which has taken the center stage is disorganization of the retinal inner layers. Again, like I said, most of it is based on common sense, that you have the ganglion cell layer and you have the right up to the outer plexiform layer. Now, if there is a disruption here, and especially in this layer of the inner nuclear layer, where there's the amicrine and the muller and all these cells, if there is fluid accumulation there, if there is a damage to that layer, then because these a lot of role of all these cells is not even known thoroughly. But what we do know is that there's a lot of cross-sectional transmission of data from one cell to the other, and it is not a parallel process which like happens in the older computers. It is transmitting data from one cell to another across, and that's why this could be one of the reasons why the data transmission is faster, and this layer is very, very important and has a very important role in that. So disorganization in this layer can cause a definite long-term damage. And that's why it is assessed independently of presence of retinal edema. And it leads to the damage to the bipolar amicrine cells, and therefore represents an anatomic interruption to the visual transmission pathway itself. A chronicity of presence of drill is obviously something which is not a happy situation. And foveal drill is obviously, which is affecting more than 50% of central 1 mm, would obviously cause a worsening outcome. Now, another interesting thing is a lot of these biomarkers, what we call as biomarkers, a lot of them improve after VEGF therapy, and different VEGFs seem to have a different role in the quality of the return to normalcy of these biomarkers. And along with that, then, is the disruption of the external limiting membrane and the OSIS junction. This is self-explanatory naturally, where you have the photoreceptors. If there's a disruption there, then obviously there would be loss. I don't know why people call it the ellipsoid zone. I still love to call it the OSIS junction, because the simple fact that it explains to you where the damage is actually taking place. So naturally, again, impairment of the ELM and OSIS junction in the central 1 mm would cause a worse visual outcome. The external limiting membrane, a damage to that seems to be a worse prognosticator than the damage to a short-term damage to the photoreceptor tips itself. And the destruction of ELM reflects impairment of the photoreceptor nuclei and severe retinal damage, whereas OSIS damage can, to some extent, be recovered with treatment. Then another important thing is the hyperreflective spots. HRS are like, like dead soldiers in a battle. So when you look at HRS, you know that either the battle has been fought pretty severely, but overall, if they are there, then it's a little ominous. The presence of HRS is a little ominous, and these are the patients which we would love to treat in a more aggressive manner, because once they start coming into the picture and they are increasing, then they can prognosticate a worsening of the condition. HRF seems to increase with progression of diabetic retinopathy, which is a close relation to the degree of retinal inflammation. And some believe that the HRS-F or the HRS, what do you call them, they may coalesce into becoming hard exudates later on. So several studies have shown rapid and significant decrease in HRF in patients who received anti-VEGF injections. Some people believe it works better with dexamethasone, but then that was in comparison to the older VEGFs. The newer VEGFs have very, very powerful action. Eyes with treatment naive DME and eyes where HRS was associated with NSAIDs at baseline responded better. Again, like I said, the presence of HRS itself is an ominous sign. So these are some references, and thank you so much for your patient hearing, though I was not able to give you a full slide views. Thank you so much.
Thank you. Thank you, Dr. Sam. That was a very informed talk. Srinivas and Dr. Jatinder, could you take the questions? We need to, Dr. Lalit has joined. Very warm welcome, Dr. Lalit. I know you are driving for a meeting. I think we should capture him and Dr. Muralidhar in this question set. Dr. Lalit, you have to unmute yourself.
Yeah.
Warm welcome.
Hello, sir.
Hi, everybody.
Yeah.
I hope you're not driving.
Dr. Srinivas, would you take
Yes, madam. Yes. I just want to ask this question to Dr. NSM sir and Dr. Jay Chablani, who has just joined, and also Lalit sir. Welcome to the ARC webinar. What is this, the importance of this BRP, that is the bridging retinal process, and the SSPIM, which is also considered as an OCT biomarker, that is the suspended particle in motion. So what are the relevance of these in real clinical applications?
Lalit, are you talking about vascular block? I just overheard. I just joined.
I think this.
Only.
This is
the question is about non-perfusion, or I didn't.
No. So SSRM he's talking about.
SSB. I think this is to Dr. Jay Chablani. I think you can just answer this if you can, please.
So what I couldn't hear the whole question, but yeah, about the SPIM, I think this was introduced much earlier, maybe around 4 or 5 years ago, where we were looking at OCT angio, and we were trying to see that what kind of cystic changes we see. In those cases, there was some hyperreflectivity seen, or because it was OCT angio, so there were hyper dots which were considered as moving particles. In fact, those particles were also reported in one of the IOVS paper, even on the structural OCT back in 2016. So what we thought is that it primarily depends upon the content of the cyst, which actually has, if it is a very turbid fluid, then you can have a motion particles, which gives you something called a SPIM. And but obviously we still don't know its clinical significance for us, but we believe that if you see SPIM, then it is more of an exudative kind of fluid, which primarily happens in patients with DME, and sometimes we see also in BRVO. I don't want to take up all the time for discussion. Anybody else has any quick comments?
Yeah, normally once you see these particles, then it like you said, it tends to tell us that the prognosis may be worse. But again, there's a lot of variability, so you cannot reproduce the same finding from OCT to OCT since they're swimming around. So that's one thing you have to keep in mind. But the fact that they are there itself means that we could be looking at a worse prognosis.
Dr. Jatinder?
Thank you. So I just have one question. I think this question has been puzzling me for a while, and I think Dr. J, or if anybody else is willing to answer this. Dr. Parveen is there. Welcome, Dr. Parveen. This doubt that I have is regarding this importance of intraretinal fluid as a biomarker. So whether intraretinal fluid itself is the cause of the visual prognosis being not so good, or is it just a part of the phenotype of the disease that is anyways has a poor prognosis? Jay, one very short answer, and then Dr. Parveen, can you just put a light on this?
A very interesting question, and I know that recent publications are showing that. So if I really have to use one line, I would say that if you are seeing chronic IRF, then definitely it is a poor prognosis factor. In cases when you have a newer naive cases, and if you see IRF, then we know that they are going to respond really well. But if you see an AMD with a long-standing IRF, it is a poor prognosis factor.
Dr. Parveen, are you there?
Yeah, so I think I agree with Dr. J. So we have these intraretinal cysts, and we, as Dr. J has mentioned, we divide them into the exudative and the degenerative ones. So exudative ones are the ones which are present early on in the course of disease, and they respond better. But if there are large degenerative ones, so they will not respond to treatment. Either way, answering Dr. Jitinder's question, I think I always look at it in a stepwise pattern, that most of these biomarkers are described in relevance to a type 1 CNV. And this type 1 CNV, you have it below the RPE. So the first thing when it presents or with activity is exudation, and you have subretinal fluid. And the next step is that now the fluid or the exudation starts happening into the substance of the retina. So by the time you have IRF, it is actually into the second level of activity, I would say. So that itself would make it probably a poor prognostic sign. And then it is causing you disruption of the nuclei, the nuclear layer and the plexiform layer. So you may have a permanent damage to the synaptic junctions which are there. So then the response to treatment, even if it happens, visually the patient may not benefit. This is how I understand the thing. As long as you see subretinal fluid, the neurosensory retina itself is very compact and the anatomy is not distorted. But once you see IRF, the anatomy of the cells gets distorted, which results in poor prognosis.
Thank you, Dr. Parveen. We shall now go on to our next speaker, Dr. Anand Vinekar, who needs no introduction, who heads the Pediatric Retina Services of Narayan Netralia, an extremely innovative individual, and he's going to tell us about handheld OCT. On to you, Dr. Anand.
Thank you, ma'am, and thank you, ARC, for this opportunity once again. These wonderful programs, and I'm so happy to be part of it. I have no financial interest. When we're talking about handheld OCT, obviously we're switching gears here, so it's going to be pediatric, and what better use of a handheld OCT than to image children. Now, historically, of course, it's not been that easy. If you had to examine a baby on OCT, then you had to do this in a lateral decubitus position, most often using either sedation or general anesthesia that was described by Patel's group in Oxford. They also described the flying baby position, which is basically a supine baby with a hyperextension of the neck. Now, these are not easy. As you can see, a whole team there. One is almost biting his nails. So it's very difficult to do in a preterm baby, especially if you want to image it during the time of the acute disease process itself. A few years, maybe over a decade ago, we tried to actually dismantle the Heidelberg spectralis to make it a sort of a handheld, and found that they were laterally inverted images, but we were still able to see what we wanted to see. And in this case, it was the flat neovascularization of partially treated aggressive disease to then target laser exactly on what MB remained. So it was useful, but it was very cumbersome. Also, we breached the warranty in trying to do that. So therefore, handheld OCT is the way to go, I guess. And this was the Bioptogen, which at that time was owned by them, and now it's owned by Leica. It was at the time we had it as a testing tool, it was not even FDA approved, but now I think there are other devices as well. So let's see what we have understood in the terms of quantum of information coming from OCT of these infants. Now, many speakers have alluded to this. This is a supposedly normal OCT of an adult, and one can talk about whether it should be called ISOS or EZ, as Dr. Goel also said. But what's really different in a preterm baby is that there is no fusion of the inner limiting membrane and the outer plexiform layer if you're born especially premature and you're being imaged in the first few days or weeks of life. And also, as you'll see now, some of these layers do not appear at birth and then start developing within a few weeks. Now, this whole process of what we now call fovealization maybe determines not only the way the fovea looks now and then later, but also perhaps influences vision. And that's really what's so important. Now, what I'd like you to do is to train your eyes on the two vertically blue arrows, which is basically the outer, which is the EZ or the ellipsoid layer or the ISOS. And that layer is growing from out inwards. On the top left is the age of this baby. So it's 38 weeks. This baby was born at 32 weeks and imaged 6 weeks after birth. So this is the 38 weeks. Sequentially, we have imaged this baby another 4 weeks later. And you can see now that right at the subfoveal area, there's just one layer, which is the RPE. And then now coming in closer and closer, trying to join itself from both sides is the ISOS. So that's 42. This is 46. 47 is almost 2 layers. And this is 48. Now, this is the same baby sequentially being imaged. So here's the importance of what's happening here. So this is a sort of a centripetal growth. Now I'm going to reverse these slides and go back here. Since all of you all were trained at the lower end of the image, now train your eyes at the superior end where the inner retinal layers are. And look at this outer plexiform layer that's really sagging below, almost touching the RPE. And now see what's happening there. Again, now don't look at the blue arrows, look up. And you see now that the outer plexiform layer is right there. It's moving up a bit, but all the inner retinal layers in that foveal center are actually moving out. So at 48 weeks, you now have a very firm fusion of the ILM and the outer plexiform layer. So critically, two things are happening here. One, centripetal, and the other one centrifugal. And I think both of them are probably happening at the same time. There's a lot of debate. This was one of our early reports saying how early can you see some of these layers like the external limiting membrane, and how significant is that to the vision itself. The Duke group has taken this to another level where they've actually looked at all these OCT changes and said that some of these layers actually correspond not only to the postnatal life, but also histopathologically. And this was their study in which they looked at the OCT layers and they diagrammatic representations of which and then correlated with histopathology. What we did was look at these babies who had otherwise normal looking maculas, otherwise all common risk factors. They only differed in their OCTs. So the one on top was a 3-month-old corrected baby with 20 by 1400 vision on the telar equity, and all other factors same, just with a better looking OCT. And by better looking, I mean now that the centripetal layer has completed itself and the inner retinal layer has moved out and there's a good fusion, and that baby has a 20 by 540. We thought it was anecdotal, and so then we extended our study to look at all these layers. So the inner retinal layer migration, that's what it's called, IRL migration, the appearance of the external limiting, the ISOS junction, what time they appear, how late can they appear in postnatal life, and how does that determine vision itself. And of course, does ROP influence all of this? So with babies with ROP, does it delay this process? Do some layers not come in at all? While we were trying to do that, we kind of serendipitously discovered that there was some sort of a disruption of these inner retinal layers, what we at that time called macular edema, which is now popularly called macular edema of prematurity. And we found two patterns. And these patterns were either the so-called classical adult CME appearance, where the foveal center is lost, there's a lot of intracystic spaces, there are high vertical reflective septae, and pattern B, where some amount of the foveal depression is preserved. There are a few septae, there is some inner retinal disorganization, so to speak, which extends beyond as well. But what was so interesting is that this peaked at around 37 to 40 weeks and went away by about 52nd week. When we followed these babies and said, okay, this was transient edema, did it do anything to them at all? And when we compared these three groups, with and without edema, we found that the babies who had the edema had poorer vision for the first 3 to 6 months of corrected life, and only after vision therapy and vision stimulation by the age of 12 months, as you can see from this graph, that they equalize. And at that point of time, pattern A and pattern B did not matter. Switching gears in terms of OCT, and one of the speakers mentioned that sometimes you're able to see a lesion much better on an OCT than a clinical image. And I think this case of tuberous sclerosis and hamartoma is a classical example. So here we were trying to show that there are different patterns that show up both on an angio and on an OCT. Some of these lesions light up on an angio, some of them don't, but almost all of them are picked up on the OCT, however small and clinically insignificant. Continuing on that foveal morphology and vision, this slide, this picture from our publication sort of summarizes it. So if there's no fusion, if the outer plexiform layer is attenuated, if the ISOS has not fused, if the foveal tent is either absent or delays, all of these, especially seen in babies with ROP, can determine poorer vision, which basically means that fovealization is not happening. In older children, as your pediatric ophthalmology colleagues might send you, they have patched, they have found that the refractive errors are not very different. There's not much of so-called anisometric metropic amblyopia. But when you do their OCTs, you find, and you can clearly see one eye here is 6 by 6, the other eye is 6/18. Patching has been done for months, if not years. And you see how thinned out that ellipsoid layer is, the interdigitating zone is. And one can tell that there is something that probably went wrong from a substructural point of view, but not from an ophthalmoscopically point of view. This is our publication on rubella and its OCT findings. I just want to bring your attention to this tooth-like jagged appearance of the outer plexiform layer, and then we found some other irregularities. The so-called salt and pepper retinopathy was not as obvious on OCT as we would have thought, but there were more changes in the inner retina itself. Down syndrome has been one of the focus of our work. What's really interesting in OCTs on these children is that they sort of resemble normal controls, in other words, children without Downs, up to the age of 2. And after 2, they start showing either stagnation of their foveal layers or actually regression patterns of some of their foveal layers. And that's really interesting because that's the time where some of their higher mental functions also take a hit, and higher order imaging of neuroimaging has shown that there are some tangles that appear after the age of 2. So is OCT of the retina mirroring what's going on in the brain? That's an interesting question. I'm just going to end with this OCT angiography study, and I know there's a separate segment of it, but in preterm babies, when you look at controls, babies who've had treatable ROP and those who've had spontaneously regressed ROP, despite having good vision, I mean 6/9 or better, and this cohort was age 5 to 10, they had abnormal looking OCT angiographies. We published in the IGO a few years ago, what are the other aspects where a pediatric OCT can be used, right from suboptimal vision to intraocular tumors, miscellaneous lesions, vascular lesions, and so on. To summarize, handheld OCT is obviously the bedside advantage. It's a tool in your hand to image small babies. It allows you subclinical assessment, as we saw in some of the examples. It definitely improves our understanding of diseases. And the most important thing is if we can predict which of these findings will have a potential for predicting vision, then that would be really good. Thank you so much.
Thank you very much, Dr. Anand. Nothing less was expected from you. Amazing talk. Dr. Srinivas, any questions?
Anand sir, as usual, wonderful talk. So we find difficulty in just imaging the periphery with the red cam. So how easy do you find in imaging these periphery, especially whether to know that it's a vascularized, whether it's a regressed, using the handheld OCT? And secondly, I should really appreciate your this thing of dismantling that Heidelberg spectralis and trying to see that. I think nobody from here don't have the guts to do that kind of sort, because we don't know whether it works back or not. But my basic question is first about the imaging of the periphery, especially in zone 2, zone 3 areas.
So Srinivas, I don't think we need the OCT to image vessels in the periphery. Using an OCT, so that our RETCAM or our NEOs are sufficient. What we were trying to do there is to, our focus of research at that time was to see these stage 2 ROPs that were not regressing. And they were going on for 50, 52, 55 weeks. So we wanted to see whether they had some characteristics of why they were not resolving, whether there was some sort of an active stage, whether there was vitreopathy, or whether there were changes subretinally and so on. So in that extent, because this is a non-contact device, you need an assistant, of course, to hold the head. And the imager will need a depressor many times to be able to bring that part of the retina into focus for if you want to image the pre-retinal changes. But honestly, we don't need to look at vessels on OCT in the periphery.
Dr. Jatinder?
I think just about Srinivas's question, I think not many people have tried that dismantling of the Heidelberg, because the company personnel, they mentioned specifically that it voids the warranty after that. So nobody dares to do that.
So we did breach the warranty. We told them, and then after it got published in Eye, they restored the warranty and then went on to develop a handheld, and they cited our paper and they thanked our management for the same.
Thank you very much. So
I just have one question, Anand.
Yes.
So, do you find this in particular like some use in macular dystrophies? So for example, where you are expecting certain changes in the offspring, say for example autosomal dominant some dystrophies, where you can do in the infancy period so OCT
Absolutely.
and actually give a prediction, just like ERG gives prediction only after 5 years.
Correct. So I think great question, and we've been reducing the number of electrophysiology tests that we've been doing at NN, predominantly because we rely so much on the OCT itself. So we are able to decide whether it's rod, cone, and based on how much choroid is lost, how much differentiation is there in the inner retina, even now start correlating slowly with their genotype. So, right, it's a great tool to detect inherited retinal dystrophies as well.
I think we'll need a good normative database as well. I'm sure you would have been working on that too.
Work in progress.
So we shall now go on to our next speaker, Dr. Srinivas Joshi, who's going to be talking on intraoperative OCT, pearls and pitfalls. On to you, Srinivas.
Yes, madam. Just a second. I hope the screen is visible.
Yeah.
Okay. So at the outset, I would like to thank Dr. Chitra ma'am and my co-moderator, Dr. Jatinder Singh sir, and all the panelists and everybody for having a wonderful evening with the OCT and OCTA. So I'll quickly go into, I have no financial disclosures, but we are using the Rescan 700. It's an integrated OCT controlled by the Callisto. And it has an IDIS that is called as the Integrated Data Injection System, where any number of OCT images can be saved and it can be switched. You can have the control scan location, 1 line, 5 line, crosshair, cube scan, and you can review the previously acquired scan during the surgery and see how it is performed after the procedure. So this, I would like to start with my, one of the very few cases when I started 5-6 years back with the Intraop OCT. So this was the case of TRD with the involving the macula and very anxious patient. So I just went ahead and did a vitrectomy. This was the membranes which is there. I just tried to peel out this membrane. So while doing the ILM peeling here, now you can notice, oh my God, did I create a macular hole in this case? So this was actually the very few cases I first started operating on the Intraop OCT, and because of which it was a learning curve and my assistant couldn't do the eye OCT by the side, but I could still have it on the other Sony microscope, but I did see it on IOCT and it was not a full thickness. It was a lamellar hole, and for this lamellar hole, my tamponading agent did not change. I just put an air and just left it in this case, and this you can see the settling TRD in the few weeks, and this is the 1 year follow-up, and this is the 5 year follow-up where the patient is now improving to 6.9. So definitely the differences between the lamellar hole and the macular, full thickness macular hole can definitely be established with this IOCT. Now coming to the next feature is the VMT. Now you can see here, it's a kinking kind of thing where we are seeing this. I just used the IVTA and stained it, and I tried to induce a PVD in this case. I just got lucky, but nowadays I'm not inducing like what I'm showing here. I just lift it and try to trim it across and leaving the central part, and so that I can trim it by the forceps. But in this case, I was just lucky, nothing came out. But what we can see here is the thin ERM. If you can see on the right hand side, the live scan, the ERM was still remaining in this patient. So this is what is important. That is, the residual membranes can definitely be seen with the eye OCT. Even after performing the procedure, you want to see there is a pre-retinal membrane or there is a residual hyaloid. And now you can see how nicely the ERM-ILM complex is getting curled over this height of the retina here. And definitely it helps you to know whether you have created a full thickness macular hole, whether you have caused a de-roofing while trying to do this. And now you can see I'm just trying to peel it across without disturbing the center. And I could still see that the part of the ERM and ILM was completely removed. The hyaloid, as you see, the IVT itself was removed. And you can see there's no de-roofing of this procedure. So my tamponading agent did not change. I just put air in this case, and the patient was doing well. Now coming to when we started with the 3D visualization 4 years back, and now you can see it gets integrated on this 3D screen. So it looks very nice sometimes, but it would be better if you have an RTVO, that is the Zeiss, because both have the similar, it's like Apple versus Samsung. So here it is Alcon versus Zeiss, but definitely you can see these kind of, I'm just doing a multi-layered ILM peel, in this case of large macular hole under PFO, so that, and now you can put on the eye OCT. You can see the flaps which are nicely settled inside. I cannot call it as a closed mac hole, but definitely the configuration, when you look at the eye OCT after this, it definitely looks like almost like a closed pattern. So I just did an FAX, and this was the OCT where the large OCT, and the patient had a type 1 closure in this case. Now these are the another set of cases where it can be useful, where you can see I'm just trying to move this. Now, if you want to insert your cutter underneath this and try to do a dissection and a delamination, I think it's really helpful. Although it would be more helpful when you have a tabletop kind of membranes where you want to go underneath and try to do the dissection with the cutter itself. You can see here, I'm just using the eye OCT to know where I can go underneath. And not just that, and I could notice that there was also a MAC hole in this case, which otherwise I could have thought it to be a lamellar hole. It looked like a lamellar hole configuration, but it was definitely a full thickness macular hole. And this eye OCT was definitely useful in identifying that and I was able to complete with the inverse ILM peeling and complete the procedure. So this is another set of cases where you can see this, the subhyaloid bleed, where after clearing the vitreous hemorrhage, and if you have a subhyaloid bleed, and definitely you can notice where the attachment of the retina is to this abnormal vitreous. Otherwise, sometimes blindly trying to pull this, trying to induce a PVD might cause the break. So here, when you just lift it and put up the broad A scan, where 6x6 slide cube, where you can see where there are attachments, so that you can just go underneath that, go surrounding that attachment and do a 360 truncation, rather than lifting up the hyaloid at that place and avoiding the iatrogenic retinal breaks in this case. So coming to the next is the persistent macular hole. Here you can see this is the case of persistent macular hole, where my first choice would be to do an ILM transplant, where if you can see here, I'm just staining it and I put a viscoat inside that so that these ILM flaps can stay inside. But nowadays I've shifted my procedure to do it under PFO, just slide it. Like how we do the neurosensory graft, we can just slide it. But here it was earlier videos where I'm just trying to use this ILM. The larger the flap is better, so that you avoid using multiple flaps, because this inadvertently we can touch the RP or the choroid with the metal forceps. So we have to be all careful in stuffing these ILM. And after that, now you can see I'm just confirming it. The flaps are definitely, it's seen clinically itself, but definitely it's of some use sometimes. And now you can see there's a type 1 closure, a few days. You can see the gas level also. And coming to the another set of videos is where everything has failed for the MAC hole, and you want to plan a neurosensory graft. In this case, I'll just directly go. Inducing a bleb also is very, very important, because you don't want to hit the choroid, and sometimes we have seen some people injecting into the choroid and causing a choroidal detachment also. But this definitely helps when you want to create a blister, and especially when you want to do a genetic therapy, a gene vector. When you want to insert it, I think the IOCT definitely comes handy. And now you can see here, I'm just using this flap and trying to place it over the MAC hole. Of course, if you have a trifine where some of the authors have described it, it's very nice, snug fit kind of the retinal graft which fits into the MAC hole. Otherwise, if you have a little larger, you can always place it, orient it based on this IOCT. You can always orient which part you want based on the, in case if it's an irregular cut of the neurosensory graft. Now, this is the another thing video I want to show. This is the case of complete vitreous hemorrhage. And now when I go inside, definitely I can see there is a RAM here. There's a, I'm trying to induce a PVD here. And after that, now you can see with the IOCT, beautifully, you can see the sub-ILM bleeds here. So this can also be seen very clearly, when, especially when the patient has vitreous hemorrhage, and we cannot try to use pre-op OCT in these cases. So here I just try to peel the ILM all over the area of the RAM, and I tried to displace that blood clot, but it was so thickly snugged to the retina. I didn't want to disturb it, because I was sure that if I try to disturb it, I'm definitely trying to have a retinal break in these kind of cases. So I just did as much as dissection as possible, and I just left it. And this was the few days later. You can see here, and 6 months later, you can see the follow-up. The patient was hand movements close to face, and he's having 3/60 vision, is probably because of the outer retinal atrophy in this case. So this is the another set of cases where IOCT can be helpful, especially in case of ERM, when we try to do it, but accidentally just peeling across might cause a very small micro holes. In these kind of cases, where if you can see here, I'm just trying to peel it from the periphery, but still sometimes it is so centrally adhered to the fovea that just across also it might cause a macular hole. And you could see in that video there's a small amount of macular hole, and this helps in changing the tamponading agents which we want to use. So the patient improved from 6/60 to 6/18 in this case. So this is the another case where I thought that everything was going well. This was the case of retinal detachment. There was a subretinal gliotic membrane over the posterior pole. I thought it was not disturbing, and let me leave it because it was, I had to puncture. But in the IOCT, you can see there was definitely a subretinal fluid, and the gliotic band was so thick, it was not allowing the retina to settle. You can even see the fold there. on the retina. So what I did was I just tried to make a retinotomy as far as possible away from the fovea, because I need to grasp the subretinal gliotic membrane as well. And now you can see I just trying to grasp this subretinal gliotic membrane. And now in the eye OCT, you can see how nicely the retina tries to snug, and the posterior pole was just flattened. Now you can see in this last images, although some disadvantages are there where you have the shadows coming off of that, but they are trying to look into how to avoid that. So this is the another case where you have a retinal detachment in this case, and suddenly you see something, a dull foveal reflex, and especially in these myopic cases, you know, where you have a very small hole or large hole, definitely you can use it, especially in case of retinal detachment where you cannot do a pre-op OCT in these cases. So this was the case of a large macular hole, which was very well confirmed, and I just completed this case, and everything went well in this case. So this was the few of my videos, the last videos, just optic disc pit, where I did induce a PVD, and although I don't think that it's of much important, but we tried to look into whether the flaps are nicely placed in the optic disc pit where you could have imaged it. And it was since a large pit, I had to take ILM grafts temporal to the macula, and I just tried to stuff it, and you could see these stuffings, and this was the results, and the patient had a dramatic improvement in the optic disc maculopathy. So this is my another last video where you can see subretinal PFO, especially when you want to differentiate between the subretinal fluid and subretinal PFO post RD surgeries. It's very important, it's very useful. Now you can see here, as I try to drain using the 42 gauge needle, you can see the retina flattening at that area. So where it helps me is these small bubbles, if they are left over, then definitely it can help you see that, so that we don't regret it later on that, oh, I left a very small bubble which was there. So we just did a study of 62 eyes, and we found, I'll just go to the last slide. We found even the surgeon's feedback also in this, and IOCT influenced the diagnosis and management in 38%, helps in diagnosis in 32% of the cases. So the surgeon's grading of the IOCT had an impact in the diagnosis and the management up to somewhere between 32 to 38% of the cases, and the mean IOCT time was 2.46 minutes. I'll not go into the detail, but another interesting I found is whether you want to distinguish between retinoschisis and the retinal detachment, especially when we are operating in the pediatric RD. And also this is the to know the vitrorenticular interface during the pediatric cataract surgery. You know, they call it as VLI dysgenesis. Sometimes these vitreous are attached to the posterior pole, and sometimes when we try to do a posterior polar, when we try to do a rhexis in the posterior capsule, sometimes the vitreous might bulge out. So they try to use this IOCT to see if there is any kind of dysgenesis and how differently they can do it. And this was an interesting paper I could find. I'd like to acknowledge my colleague, Dr. Giriraj Vibhute, for helping me in editing these videos. And thank you very much for the patient listening.
Thank you. That was an amazing collection of videos, amazing talk. Dr. Jatinder, we have actually 1 hour and 6 more speakers. So I think just one question.
Yeah, just I would ask Dr. Muralidhar, where does he feel that with his kind of expertise, where does it feel like the intraoperative OCT fits into a surgical case?
Thank you, Jatinder. I don't have any personal experience of using intraoperative OCT, though I wish I could order one, but I don't have personal experience. But looking at the data and what Srinivas showed, photos, there are many situations where we feel we should need one, like macular hole surgeries, ERM surgeries. And I wanted to ask Srinivas one thing. Have you found it useful in one of the situations where we clinically find very difficult is high myopia with macular hole detachment, or even in macular hole in high myopia? And we know that even normal OCT is difficult to image in that kind of a situation. Have you found intraoperative OCT to be useful in this particular clinical situation, surgical situation?
Very good question, sir. In fact, I have tried in most of these myopic detachments, but if it is a very high myopia, we have failed to even image, because this is not I would like to say the Fourier domain or the SS OCT what we have, or it is just 28,000 A scans per second. So we are looking into more and more kind of things where we can have updated technology of the OCT, where we can have the angiography, where we can have sweat source kind of thing, and a different kind of lens. If we use, probably we can use it, because I use the flat lens or the macular lens in very high myopia. Somehow I have not been able to image the posterior pole so well, especially trying to look at the small macular holes, especially when you don't have a good contrast.
Two quick comments from Dr. Mudit and Dr. Barbara. Mudit, go in first, and then.
Yeah, so thank you so much. I think Srinivas has already covered most of the uses, and so did Dr. Molidhar when they were discussing about the role of intraop OCT, specifically in macular surgeries. But I think going forward, one more area, though it's probably early days for it, but going forward, one more area where intraop OCT will become important will be subretinal delivery of drugs and gene therapy. So that will be another area where intraop OCT will have a huge amount of importance, because if you are trying to assess the drug delivery and whether you have entered the subretinal space properly, that is another area where intraop OCT holds a huge amount of importance.
Dr. Barbara?
I wanted to say that even here, it depends on the type of technology. I've been using since 2016 the Leica model, and they use a wide field type. So even in high, I would say that 80% of my patients are high myopic eyes, because that's mostly what I do. And so you can always grab very good images, which I use to calculate the height of a macular buckle, for instance, or to peel an ILM when there is no contrast, because that's a peculiarity of these eyes. You don't see the holes sometimes, and the OCT is extremely helpful. And I think that to conclude the intraoperative OCT, when you use it on a daily basis, you see that the microscope is telling you what you do, your maneuver is describing your maneuver very well, but the intraoperative OCT tells you the response of the tissue to your maneuver. So you have a constant confirmation of what you're doing, and actually it expedites the surgery in the end.
Thank you. We shall go on to our next speaker. We'll have to be a little less on discussions. We have 6 more of them, very good talks. And we have Dr. Pradeep Sagar, who's a consultant vitreoretina services from Shankara Eye Hospital, Shimoga, and he is going to be telling us guidelines on use of OCTA. On to you, doctor.
Thank you, ma'am. Are my slides visible?
Yes, yes.
I would like to thank Dr. Chitra ma'am and AAOC for giving me this opportunity. I'll be discussing on the guidelines on use of OCT angiography and standardization of OCTA reporting. I have to make it clear that there is an ongoing attempt to frame the guidelines and standardize the terminologies related to OCTA, and the guidelines are not available yet in all clinical scenarios. So my presentation is mainly based on a few attempts, a few articles which have tried to standardize the OCTA nomenclature in different retinal conditions. So first, I will be discussing the guidelines on use of OCTA, the utility of OCTA in clinical conditions, and what protocols to order. So the clinical conditions, the most common would be the diabetic retinopathy. There was a consensus among the experts that a set of OCTA parameters should be included in staging of diabetic retinopathy, which includes the vascular density, the foveal avascular zone parameters, the amount of flow deficit areas, presence of intraretinal microvascular abnormalities, and presence of neovascularization. So the other important condition is macular ischemia. We all know that OCTA is very helpful in detection of macular ischemia, and a strong consensus was there among the experts that it is helpful. But we know that there are various other FAZ parameters such as the A circularity index, the FAZ area, and there was no consensus among the experts on which parameter should be used to define the presence and the severity of macular ischemia. We know that in macular edema, the assessment of macular ischemia would be complicated by segmentation errors and the presence of cystoid spaces. Here we can see an example in which we can see in the superficial capillary plexus, even though there is edema, it is less affected, and we will be able to assess the foveal vascular zone. Whereas in this case, we can see that due to the segmentation artifact and due to a very thin inner layer of the cyst, the FAZ appears to be enlarged, and it's a false impression. So there is a need for standardization and need for guidelines on utility of OCTA in macular edema in cases with macular ischemia. Moving on to retinal vein occlusions, there was a consensus among the experts that more than 30-degree absolute decrease in flow area has to be used to define ischemic CRVO from non-ischemic CRVO, but there was no guidelines on classifying BRVO. So in uveitis, the experts opine that it helps in the detection of CNV neovascularization elsewhere and neovascularization at the disc. There was consensus among the experts on the definition of the neovascularization elsewhere and neovascularization at disc. That is, it was defined as a supraretinal flow with breaching of ILM on the OCTA cross-section and presence of an irregular dense network of vessels on a OCTA NFAS. But the consensus regarding the use of the term macular neovascularization, which was advocated by the consensus on neovascular AMD nomenclature group, was not accepted by the group on uveitis experts who felt that the terminology may not be applied to inflammatory choroidal neovascular membranes. We know that OCTA plays a very important role in diagnosis and management of AMD and pachychoroid spectrum diseases, but as of now, there is no guideline on use of OCTA in these conditions. So what scanning protocol to order? We know that there are guidelines to say that neovascularization has to be used for the staging of diabetic retinopathy, which can be detected on Oct. But here we can see that there is an example. This is a wide field, a 9x technically not wide field. It's a 9x9 mm scan in which the NVD is not very well evident, whereas in a 4.5 mm scan, we can see that the NVD is very well seen. Similarly, here we can see that there is a flat irregular PED on OCT. There is no obvious network on 6 mm Oct, but a 3 mm Oct shows a network. So what we need to understand is that it's not just that what parameters have to be included. It's also that we need a consensus on what scanning protocol has to be used in order to identify these entities. But as of now, there is no consensus in this field. So moving on to the terminologies used in OCTA reporting. So wide field OCTA. There was a consensus among experts in the field of retinal vascular diseases that more than 90-degree field of view should be considered as wide field, and the experts in the field of uveitis suggested more than 70-degree field of view as wide field. So what we need to understand is the manufacturers have to provide a field of view of each protocol for this standardization. So the area of reduced signal, we see in OCTA the areas with reduced signal, and it has been termed in literature with various terminologies such as flow void, capillary non-perfusion, grayish area, no flow area, flow deficit, flow attenuation, and so on. So there was a strong consensus on classifying the reduced signal on Oct based on the cause. For example, it can be due to absence of perfusion, as we can see over here. But we have to understand that it would not be possible to be certain that it is definitely an absence of flow, as even a low flow may be seen as a reduced signal on OCTA. So the reduced signal can also be due to a low flow, as I already mentioned. For example, within an aneurysm, here we can see that there is an aneurysm, and here we see that this area is seen as a reduced signal. The reduced signal can also be due to vessel displacement. For example, in cases with cystoid macular edema, here we can see that due to the presence of this inner retinal cyst, we see that there is an area of reduced signal. So it has to be classified separately. And it can also, the reduced signal can also be due to presence of hemorrhage or hard exudates, which results in blockage. As we can see over here in this choriocapillary slab, we see that there are areas of reduced signal, but this is actually due to blockage and not a true reduction in flow. So though there was a consensus on classifying the reduced signal based on the cause, there was no consensus on what term has to be used. in the discussion, there was this term used, which is the decorrelation signal. That's the reduced decorrelation signal, which actually seems to be appropriate because in OCTA, what we are measuring is the decorrelation signal. But the experts were not comfortable with the term decorrelation signal, and they preferred the term signal abnormality, and they used the term signal abnormality due to projection artifact for flow change due to projection artifact or projection artifact removal, signal abnormality due to flow displacement for flow change due to vessel displacement such as cystoid macular edema, and flow deficit for flow change due to ischemia. But they specified that none of these terms should be officially recommended for now. So the term large flow decrease was defined as a reduced flow area of more than 30% of absolute imaged area. They defined a meaningful change in percentage of flow on wide field OCTA as an increase or decrease of more than 30%. And moving on to the reporting of quantitative parameters, there was a strong consensus on use of automated measurement in square millimeter using OCTA manufacturer software to measure the reduced flow area, as like there are various other like parameters, the quantitative parameters other than just the reduced flow area, but there was no consensus on those. And the consensus was that if the manufacturer does not provide an automated software, a third-party software such as an ImageJ can be used. I would just like to point out that, like, you can see that this is a 4.5 mm scan and the 6 mm scan, and this is of the same eye captured at same time, but we can see that the vascular density measured in these two are different. So what we need to understand is it's not just that the automated software, we have to specify that which particular protocol has to be used. Then only we'll be able to get a standardized reporting. So to summarize, guidelines on use of OCTA has to be tailored for each disease pathology, and it may not be same. And standardization of terms and recommendations on use of specific protocol is required for each entity. And there's an attempt in this direction, but further progress is required for a better standardization. Thank you.
Thank you. Thank you very much, Dr. Pradeep. You tried to make it as clear as possible. I would ask Dr. Jatinder Sinwas just one question from either of you, and we should go on to our next talk. And Mr. Sunil, can you start timing? I should have asked you right from the beginning. Are you there, Mr. Sunil? No. Yes.
Dr. J, can you shed more light on what's there for the future? Like, how do you think this terminology, or which are the most acceptable terminologies so far? I mean, Dr. Pradeep has done a very excellent job summing up everything. But just two take-home points. What are the signals for freshers or for exams? If you have cases, what are the things that should be? What are the terms that should be used, like in general communication?
I think that we are really far from bringing everything into a standard use. I think we are just reaching to the OCT. OCT NGO is still far away. But I think using the term reduced signal or signal abnormalities is going to be, I think it's going to be pretty much acceptable. But more important to me for the beginners would be that, Rupak's talk on OCT artifacts, because that is something which we should be looking much more carefully and making sure that what you are interpreting is actually the real pathology instead of just an artifact. So nothing much to add, because I think Sagar, Pradeep covered it really well. I'll just let the next speaker speak, considering the time shortage we have.
Yeah. Thank you very much, Dr. Jai. And we shall now go on to our next speaker, Dr. Rupak Roy, who is a Senior Consultant Vitreoretina Services at Shankar Nethralaya, Kolkata. On to you, Dr. Rupak.
Am I audible and my slides are visible?
Yes.
Yes, sir.
Yeah. Thank you very much, ARC, for this opportunity. I'll be speaking on OCT angiography artifacts. So if you look at the prevalence of OCT angiography artifacts, it's very common. In some cities, it's up to 70 to 100% in imaged eyes. So it could be patient-related, software-related, or operator-related. So patient-related could be motion artifact, software related could be segmentation and projection artifacts, and operator related could be defocus artifacts. So what are motion artifacts? They are basically happens due to eye movements, and the software then goes on to correct, does corrections for the eye movement, and we get artifacts. So it is very common to see such blink lines when the patient closes their eyelid. So you can see the blink lines here. Also, due to displacement, we can have linear black lies and distortion of the vessels, which are again types of motion artifacts. Another type of motion artifacts that you can see, as you see here, are doubling or non-overlapping multiple images, which are again due to software correction. Quilting is another type of motion artifact where you get crisscross structures and due to multiple saccades. Another type of motion artifact that can be seen is the banding, which can be due to the corneal refractive shift due to blinking, and part of the image goes out of focus. Now, one of the most commonest artifacts that we encounter in OCT angiography is the projection artifacts. So projection of superficial structures on deeper layer. So superficial vessels reflect back to the light of the camera, the remaining light, which is RP. Decorrelation at RP mimics superficial vascular bed. So this is an example from one of our papers where you can see this is the devascular plexus, where you don't expect to see this kind of vasculature. So this is a projection artifact. Nowadays, most of the machines have this projection artifact removal software, which can help us in reducing these projection artifacts. Similarly, here you can see there are a lot of projection artifact, and when you remove the artifact, you can clearly see the CNVM. So coming to the most clinically affecting artifact in OCT angiography, that is the segmentation artifact. This occurs due to misidentification of the retinal boundaries and showing structures of different layers. So before we go into the segmentation artifact, we have to understand how the OCT angiography slabs work. So each slab is generated by selecting an upper and lower boundary. The vessels that lie within these two boundaries are projected to produce an en-face image, and algorithms automatically detect predetermined retinal boundaries based on distinguishing characteristics such as reflectivity and texture. So, but there are pitfalls. However, segmentation algorithms were developed by imaging healthy eyes with distinct retinal layers. Disease pathologies such as fluid seen in DME, drusen in AMD, and even myopia can drastically alter retinal anatomy and cause segmentation errors. So what are the sources of segmentation errors? They're epiretinal membrane, macular edema, ischemic retina, where you have altered reflectivity and RP elevation. So I will, so what are the ways to correct segmentation error? This could be slab selection or manual segmentation. Coming to one of the clinical situations here, this is one of our patients where you can see, this is a structural OCT. You can see there's a double layer sign and subretinal fluid. But you go to the OCT angiography tab, this is a hydraulic spectralis machine, but you are not able to see any neovascular network. So in these cases, you can do manual segmentation and you can do a manual selection of the slabs. This is available in all machines. This is what I'm doing in a Heidelberg machine. I am manually selecting the slab here. I can do that. And now this is the slab thickness that I have decided on, and I'm slowly pulling it down to investigate the retina in a much better way. And you can slowly see a neovascular network that is emerging here, which was not seen in the default tab. This is another case. Coming to another case, this is a case of a lady with the parafoveal telangiectasia. This is a multicolored image which shows the reflectance abnormalities. And this is a structural OCT, which basically shows a hyperreflective space. And I go up and down, you're not able to see any CNV complex here. But strikingly, when you do the OCT angiography in this patient, what we are able to see, this is the default OCT angiography tab. And you are able to see a large network here, which is not correlating to what we are seeing in the structural OCT. So in this case, again, we do a manual segmentation, and as we pull the cursor down, you see this signal is emanating from the choroid. Because of the thin retina, the choroidal vessels are actually being seen as a network, which is not a true network. And coming to my last video, this is a case. This is a case of CRAO. This is a multicolor image. And if you see the OCT, you see the reflectivity of this is widely altered. So if the reflectivity is altered, the OCT angiography is not able to segment. And here we have an option of segmenting layer by layer in the Heidelberg. If you see the IPL segmentation here, it is way off the mark. So it should be somewhere here and it has gone here. So you have the option of correcting the segmentation error manually by drawing a line where the IPL should be. But the problem is this approach is you have to do it for every B-scan slide to get a composite picture. So in a nutshell, these are the basic errors that we can see, artifacts that you can see in OCT angiography, and understanding them is important to interpret images to come to a clinical decision making. Thank you very much for your kind attention.
Thank you very much, Dr. Rupa. Srinivas, could you take a question? Srinivas, are you there? Yeah.
Rupak sir, wonderful talk. It's so difficult topic that you covered it in 8 minutes. But again, my question still remains is, see, to do one layer itself, you might have to segment it 10 times or sometimes up to 50 times. So in the busy clinical practice, I still, how do we do this? Any quick tips that we can do that, or is there any new softwares which are coming to do it? Individually doing the Brooks itself, sometimes it might take so much time. You might have to do 10 or 20 or 30 each layer, slab by slab, slab by slab. So
yes, so Srinivas, you're absolutely right. In a busy clinical practice, it is extremely difficult to do slab by slab correction. But what we can do is that manual slab selection, where you can select a predefined narrow slab and then take it up and down throughout the on-fast image to identify the vessel structures better. But still, in a clinical practice, sometimes it is not possible.
Jay Boss, any quick tip?
I was wondering that why do you want to see all 10 layers? You just need 2 layers, right? You just need 2 layers. So pick up SCP and DCP, that is enough for you. But now the segmentation algorithms are superb, and even the Plex Elite provides fantastic segmentation. I think the most important message from Rupak's talk is that, I think that OCT angio actually confuses us more, which leads to unnecessary treatment and unnecessary diagnosis. So it's better to, follow Rupak's talk and do not diagnose CNVM unnecessarily. That's all I would say.
Dr. Ritesh and Dr. Mudit, just one word from you.
Yeah. So to one quick comment, Jay very rightly said, most of the confusion happens when we are looking at choroidal neovascular complexes. In the newer machines, we, instead of looking at the normal the choroidal cut, just take the RPA fit scan, and you will be able to pick up lesions much more quicker. You need not go through all the scans that's just one small tip. You can try and pick up RP fit scan and just try and see that.
Dr. Mudit?
No, I think nothing else from my end. Ritesh and Dr. Jay have already covered most of what has been done. And Dr. Rupa, great talk, seriously.
Yeah.
It's important to understand these artifacts. Otherwise, we'll end up erring most of these times.
Yeah. So
I think let's make a comment, quick one. Just like Ritesh mentioned, that we can look at the RP fit, but sometimes the example which Rupak showed, which was in case of Mactil, those are the ones which have those new vessels very close to the pigmentation, or they can have it in the avascular slab. If you just use the RP fit, you may miss them. But again, as Jay mentioned, 1 or 2 slabs you need to identify and look carefully at that. Very good talk, Rupak. Thank you.
Very good talk. We'll go on to the next speaker, and Jatinder, you would have to take question here. We have with us Dr. Divyansh Mishra, who's a consultant from Shankara Eye Hospital, Bangalore, and vitreoretina specialist, and also great interest in ocular oncology. And he's going to tell us how to quantify OCTA parameters. On to you, Dr. Divyansh.
Yeah. So good evening all. Thank you AIOS, ARC, and thank you ma'am for the opportunity to be a part of such an interesting group of individuals who are so well versed with Octa. So my topic is quantification of OCTA parameters and its clinical application. So when I first started looking at what am I looking and what I want to present. So I was really lost in words. So there are so many short forms, so many things which has to be understood, so many intricate details which have to be understood in the whole talk. So again, no financial disclosure. Very important that before we understand the talk, we need to sit with the OCT machine and another, which is most easily available software, which is called as an ImageJ. So I tried my hand on it and understood a little bit out of the whole gimmick. So usually when we see an OCT image, as Pradeep and Rupak sir has told, that there are many issues in one, getting an image, second, reducing the artifact, and third, analyzing an image. And finally, we have a report with us. Once we have a report, we see, okay, whether there is neovascularization, yes, no, that's good. And then we move on. But that's more to it. And what's more is a quantitative analysis. So quantitative analysis is to sit with the machine, sit with the software, and invest a lot of time to see lesions which have to be marked, identified, and also utilized. So like in this case, what we are seeing 3 arrows. The first is identification of the FAZ, which is distorted. How we do that is a measuring tool within the software itself, or either use the vascular density index ratio so that we understand what all blood vessels or how is the vascular density at that particular point. So to understand, there are multiple quantitative analytic terminologies, and the most important being that the OCT image has to be first segmented, binarized, or what is called as skeletonized, and then utilized for further evaluation or quantification of it. So like either vascular perimetry map or a factual density map. So going to the first letter or a word, which is blood vessel density, aka vascular density or a vascular area density, capillary density, or area of non-perfusion. So this is actually a ratio of image which is occupied in between the blood vessels. And as you can see over here, this is a very important table which I have put up. So this shows that what are the implications. So the implications or applications are the vascular lesions, glaucoma, vein occlusions, and sickle cell retinopathy, diabetic retinopathy, and AMD. And this shows that what can be utilized. So in this, what we can see is the inbuilt software of the machine can be utilized, or a custom-based software needs to be utilized, or very important in certain cases, customized OCTA itself is required. So in this case, as we had discussed earlier, that we need to identify the vascular density, so we can identify the FAZ, or either for non-perfusion areas. Like in this case, as you can see, this is a similar image which I have binarized, and we can identify the non-perfusion areas much better. Or otherwise, there are some studies also which have suggested that the non-perfusion areas start somewhere at around less than 30 degrees. So an octa of 12 by 12 would be able to identify very early changes. It is also useful in other cases like vein occlusions, where we are able to identify the non-perfusion area. If there are collaterals or new vascularization at the disc, that also would be helpful. This is a very specific case where, as you can see, this is a case which has been done a brachytherapy. So this is what we are seeing, a CNP area in a case of brachytherapy, which is called as a radiation retinopathy. So this can also be identified using an octa. And the next one is blood vessel caliber, or a BVC, aka blood vessel diameter, or a width, or a, so in this case, what we do is to identify whether the vessel is dilating or shrinking, what it can be utilized in cases of vascular pathologies. And as we can see over here, yes, the OCTA software can be utilized, or a customized software can be utilized, or a customized machine. Like in this case, what we can see over here is the OCTA 12 by 12, which is zoomed in. This is a 3 by 3 image of the same lesion, where we binarize. So once we binarize, and this is an overlap of that similar binarized image, and then we identify the diameter, and it is correlated to another OCT software which can be utilized also, or a color photograph. Blood vessel tortuosity. So what is tortuosity? Yes, to measure the degree of vessel distortion from the straight line. This is again utilized in cases of vascular lesions like diabetic retinopathy, vein occlusion, or sickle cell, and others. Very important, yes, the present software, what we have, does not help you. There should be a specialized software or some kind of a specialized OCT. So what does it actually mean? It's not that the blood vessels are a straight line. There is a real distance to it, and that is what is how the BVT, or a blood vessel tortuosity, is calculated. And vessel perimeter index, as this is the ratio between an overall counter length and the vessel blood vessel boundaries. And very important to identify dropouts or ischemia. Again, vascular lesions would be helpful to identify with that. And most importantly, you should have a very specific software to identify it. As you can see over here, the same octa image is binarized, and then what you do is this vessel perimetry map, And as you can see, each blood vessel has 2 lines to it, and that is how it identifies the perimeter of that blood vessel. This is very easy. Foveal avascular zone, we can discuss further also, as we are seeing over here. It can be utilized in all vascular lesions and pathologies, and the available software presently can be utilized, or additional softwares can be used. As in this case, we discussed earlier also, the most important is not only FAZ, but the contour irregularity. So irregularity is how regular the edges are, or the circularity as what is mentioned over here. And what does it signify is, in this case, as you can see, it's not very circular. And so when we try to measure it, it gives this round. So this is what the circularity index is. If it's near to 1, that is more circular, and that is what is near to normal. But the lesser than that is what is abnormal. So then comes the vascular complexity index. Again, the words are very confusing. So this is a fractal dimension which has been utilized for a parameter to quantify the VCI. So to understand, very importantly, it identifies in squares, a small 3 by 3 or a very smaller squares. It identifies the original image, what is a control image. It sees whether the vessels are normal in that, and that is compared onto the abnormal blood vessels. As is, in this case, we can see the orange areas or the yellow areas are the abnormal ones, and the more darker oranges are much more abnormal ones. So as you can see, as compared to control, in NPDR, you would see milder changes, and in PDR, you would see much more advanced changes. Again, a very specific short form of BPA, or a branch point analysis. Yes, we come down to the details of it, what exactly it is. So it is something is where there are 3 or 4 dots, as we can see over here. Branch point is a vessel skeleton where a green pixel represents the branch point over here where it branches. And the red pixels are actually the 3 branches of the same vessel, and the blue pixel is actually this blood vessel which is in discussion. And that is when they identify what is the angulation in between, and that changes in cases of vascular lesions. Differential artery and vein, again, in this case, what they utilize is the color photograph, and they compare it and identify what is artery and what is vein, and then they binarize the OCTA image, and then both are overlap. And that is how this differential artery vein analysis is done. Flow analysis, there are multiple associates of flow analysis, like flow indices or adjusted flow index, but it requires very, very special softwares to do that, as we know. So this kind of software would help you give the perfusion index, either vascular density or a flow index, as we can see in CNV analysis, which is very commonly done either by morphological association or probably quantitative association. And it can be done with your presently available software. As you can see, we can measure the diameter and follow up a similar case. This is a published literature which we had done before, case of a pseudoxanthoma elasticum, where there was progression of the CNV lesion. It can be also utilized in cases of a naive quiescent CNV, and also not only neovascularization of a choroid, it can be used for neovascularization of the vitreoretinal interface. And if the patient is allergic to a dye, we can do a wide field montaging OCTA, and that can help us give an understanding. Some special circumstances, like our publication regarding the tumors, like this can help us identify areas of choroidal hemangioma, which has abnormal blood vessels in the superficial and deep capillary, plexus. And again, to identify very unobvious choroidal hemangiomas, OCT and Oct can help us identify very unobvious cases also. Oct can also help in cases of RP, where we can see the choriocapillary slab is showing that the central choriocapillary is only surviving, but all other outside the macular area is lost. And yes, it can also help in cases of retinal hemangioblastomas. This is a case, immediate laser, we can see the decreased vascularity. And in cases of optic disc melanoma, where the decreased vascularity can be identified. So the point of discussion is the fundus photo gives us an NFAS or a single spatial resolution. OCT gives us an understanding, yes, there is something abnormal, but Oct gives us a very good understanding that there is what abnormality exactly it is, as it is a high resolution and depth resolved kind of an image. So the point of discussion at this point is whether quantitative analysis of an Oct can be done by a machine, either by a machine learning or an AI and artificial learning or a deep learning, and help us give a better result. Thank you. Thank you again.
Thank you very much, Doctor. That was an amazing talk. And Jatinder, would you take any question now?
Excellent talk as usual. I just have 3 quick comments from Mudit, Jay, and Ritesh. which is your one favorite OCTA quantitative parameter that you would use, be it pathology specific or zone specific or say for slab specific? Which is the one which you would most commonly use in your day-to-day practice?
Unfortunately not. I'm still struggling to segment the layers in the clinic, like Srinivas said. I don't think that we are still bringing it in the clinical practice.
Yes, Dr. Mudit. You have to unmute yourself.
I apologize. Yeah. No, even I don't actually have any specific favorite slab or something. It's like what Jay said. It's still a work in progress, which we are evaluating most of the times in our clinics.
Ritesh?
Ritesh?
Till Ritesh starts speaking, I would say that not to disappoint Jatinder sir, is that I think FAZ acircularity index is most reliable in my opinion, because at least you can see the dark areas. I still do not trust the vessel density algorithms. I don't think that we are still measuring CNV areas. That could be the second favorite of mine, but qualitative analysis of CNV is something which I would prefer in the clinic.
Okay, thank you. We shall now go on to our next speaker, Dr. Jatinder Singh, and he's going to talk to us on a very important talk, differentiating type 1 CNV and PCV. Dr. Srinivas, you would have to take the question.
So are the slides full screen?
Yes, sir. Please, you can go ahead.
So thank you, Dr. Chitra, for this opportunity. So I'll be talking on how to differentiate, or whether do we need to differentiate BVN from a type 1 CNV. So PCV, even after 40 years after it was...
So sorry to interrupt, your voice is slightly feeble. If you can...
Yeah, I'm present. Yeah. Is it better now?
Yeah, much better.
So even after 40 years of its formal introduction by NUZ, the PCV disease as such still remains an enigma, and it is yet to be comprehended completely. There are certain unique features that help us to differentiate clinically and with imaging, but there is a clear-cut need to differentiate this from the neovascular AMD because of there are some similarities, but more because of its differences. Primarily, the natural evolution of the disease, the clinical heterogeneity, and the long-term prognosis of PCV significantly differs from the typical AMD. So why do we need to differentiate is not just based on its clinical features, but even the choice of therapy is sometimes different. We would prefer a particular anti-VEGF for PCV as compared to a typical AMD. And also if and when the PDT becomes available, the additional use of PDT can be like disease changing in cases of PCV. The diagnosis of PCV typically depends on strong clinical suspicion, and then based on the OCT findings, we can come to a decent narrowing down of the diagnosis. However, ICG still remains the gold standard for the diagnosis of PCV because it picks up the polyp and the branching vascular network, which is the pathognomonic features of the PCV disease. So earlier days when ICG was not so good, people used to rely on FA, but in less than 10% cases, these polypodal related CNV membranes would be picked up as classic CNVMs. The rest of them would be labeled as occult CNVM. But with the advent of AI and its coupling with the FA, there is a report which suggests that around 85 to 90% of these PCV membranes can be accurately diagnosed just based on deep learning network and the FFA. However, for the time being, ICG still remains the gold standard, but because of its limitation in the Z-axis primarily, and also because of its invasive nature, people have moved on to OCT-A to diagnose this entity. So there is a good agreement between the swept source OCT and ICGA, as has been shown by this paper. However, there are certain cases which may not be picked up on ICG because the polyps are either unambiguous or because the patients have been treated and they are not treatment naive. the treated eyes, the polyps might undergo regression, and when you want to later revisit the diagnosis, it may be a challenge to differentiate this PCV from a typical AMD. So what is type 1 ANV, which has been defined as a neovascular complex between RP and Brooks membrane. And this is very similar to what is the definition of BVN as proposed by many authors. So any neovascular network in the sub-RP component, in the sub-RP compartment, in eyes that have typical features of phenotypic features of PCV. So here now indirectly we have to pick up phenotypic features to call it as VVN, otherwise it should be labeled as type 1 CN. So vascular network is basically described in these three headings: the shape, the branching, and the morphology. And there is a study to suggest that the shape and the branching, or the numerous tiny capillaries, are predominantly seen in PCV. However, the p-value was barely significant in this. The characteristics of BVN on OCTA are basically three types: the trunk pattern, that is the type 1, which shows a main trunk and numerous vessels which radiate outwards towards the periphery. Type 2, which is the glomeruli pattern, which does not have a trunk, and the whole capillary network appears as a glomerulus. And the type 3, that is the stick pattern, where there is no identifiable feeding vessel, and there are fine vascular networks. So identifying these three patterns actually helps to differentiate and probably prognosticate these cases, especially when patients are treated with the combination therapy. So PCV is not just straight one type. There are now subtypes recognized: the type 1 PCV and the type 2. Type 2 is what is typically described as typical PCV, which has no or faint BVN, but predominant polyps. The type 1 PCV is apparent BVN on ICG and is similar to AMD in certain parameters. It has larger lesion size, smaller polyps, sometimes which is not clearly seen. Choroidal thickening is lesser, no pachychoroid specifically associated with it, and the response to PDT and the prognosis is similar to AMD. So type 2, I think there is not much confusion. If you are able to see the polyp and if there is no feeder vessel, we would probably label it as type 2 PCV. So type 1 PCV, which is the polyps which are associated with neovascular AMD, as some have called them, is also called as the polypodal choroidal neovascularization. So these are the examples based on the schematic. You can see there is a feeder vessel. The feeder vessel is actually not breached the Brooks membrane and it's not come above the RPE, and till that time it is type 1 PCV. So the membrane extends laterally in the sub-RPE component, in the sub-Brooks component. The type 2 PCV has now breached the Brooks membrane and is now laterally grows between the Brooks and the RPE. So these are the cases which have lateral growth, which is very limited. So you will not see much of a network. So these are the clinical pictures and the OCTA pictures. You can see this network and the polypodal choroidal neovascularization, which shows the features as described. So whether polypodal choroidal neovascular membranes are just like another form of a phenotype of neovascular AMD, no, there are still differences. The AMD is seen in little elderly patients. There are racial predilections. The Asians show this PCNV more often. And the visual acuity is, though not as good as the typical PCV, is better than the neovascular AMD. In addition to that, the response to therapy, the benign course of the disease, the lack of drusen and slightly thicker choroid also help to differentiate PCNV from neovascular AMD. This has also been supported by clinical pathological evidence because of the immunohistochemistry and certain certain histological markers. It is suggestive that the PCV is a distinct disease from neovascular AMD. There's a recent paper on fractal analysis, which studies the vascular perfusion density, the fractal dimension, the lacunarity, and it has shown with binarization, just like ImageJ software. This is a fractalysis software, which has shown that the PCV and PCNV, the type 1 and type 2, there are certain differences. The type 1 CNV and PCNV have similar neovascular architecture and branching complexity. The PCNV is more heterogeneous than the type 1 CNV that's associated with neovascular AMD. But this may be also because of the shadowing artifact from the massive subretinal hemorrhages, which was associated in almost 1/3 of the cases. And PCV eyes also show higher vascular perfusion density as compared to the type 1 CNV. So in spite of the advances that OCTA seeing these years, I mean, there are still limitations, not primarily because of the machine itself, but inherent to the disease pathology. The large PEDs, the extramacular polyps with exudation, hemorrhage, the massive organized hemorrhage and exudation, and polyps with significant BVN can still cause confusion. You can see in this picture from the literature, you can see the neovascular network of AMD, which can be very similar to a PCV case, and a case of CSE, which is again could be a precursor of PCV. So what should we call it? Should we call it as BVN? But the recent literature from the Asian Pacific has shown that it's better called as benign neovascular network rather than calling it as branching vascular network. The neovascular network observed in the same plane as type 1 CNV, that's between the RP and Brooks. The branching neovascular network or type 1 neovascularization then should be used as purely for descriptive purposes. And if there is a discussion specific to the cause, if it is associated with pachychoroid, in those cases, it can be probably labeled as pachychoroid neovasculopathy. So to conclude, the morphology of vascular network is not just affected by the disease per se, but is also affected by the activity and the chronicity of the disease. And without visualizing the polyps clearly, it still remains a challenge to confidently differentiate PCV from the type 1 CN on Octa. Thank you so much.
Very nice talk, Jatinder. Srinivas, do you have a question?
Yes, so Jatinder sir, very well, good talk. I would just like to know whether when they say that the signs of activity on Octa, like there is the branching dense capillary network, the presence of anastomose or loops, and perilesional hypointense halos. And are these pretty much similar? These biomarkers are pretty much similar in cases of PCV and CNV, or how do we look in for the biomarkers in either of these cases?
Frankly, I have not looked into that depth of looking for biomarkers. We're just looking as actually just for diagnostic purposes. Like my main interest was to differentiate a network. So just by looking at the network, can we actually differentiate PCV from AMD? And I have found that even the literature is divided and there is no clarity on a particular network being called as a BVN vis-a-vis type 1 CNV. So regarding your question, I have not actually looked into biomarkers. Maybe Jay or Ritesh can shed more light on this.
Jay or Pradeep or Divyansh, Ritesh sir, anybody? Yeah, Ritesh bhai, please go ahead.
Yeah, I have looked at these morphological networks only purely on basis of whether to look at them as active or dead networks. Okay, so we look at those prune tree appearance and the loops and all, and the perilesional halos. Regarding comparing BVNs from PCV in terms of these morphological parameters, I don't think I have really looked into it. I still go by what Dr. Jatinder had put up in his last slide. If I identify a polyp, I pick it up as a PCV on Octa. Otherwise, it's practically very difficult to differentiate the two kind of networks.
Thank you.
Dr. Jay, quick comment and we can move on.
Nothing to add. I agree that it's almost impossible to differentiate unless you change the level of the segmentation. Then you may be able to see how they are located as per the differentiation what Dr. Jatinder explained.
Thank you. We shall now go on to our guest speaker, Dr. Barbara Parolini, who is a vitreoretina consultant, a very prolific one at that, from Verona, Italy. And she heads the Department of Ophthalmology in her center. And she is going to be showing us a fantastic array of images to the wide field OCTA coming of ages. On to you, Dr. Barbara.
Thank you, and thank you for your kind invitation and allow me to explain about what I found in this great topic. I have had wide field OCTA since 2 years, so I had the opportunity to try it on a huge variety of conditions in the retina, choroid, iris, and conjunctiva. You all know about the standard field. We've seen a wonderful presentation showing the advantages of angio-OCT over more invasive techniques. So we can extend the same concepts on the peripheral retina and open up the indications. So this is a normal wide field angio-OCT of the superficial capillary plexus. But the question is, to which extent with wide field angio-OCT can we avoid fluorescein angiography and ICG? First of all, what do we want to know from fluorescein angiography and ICG? We want to know about ischemia, about leakage, and about the presence of abnormal vessels in the retina and the choroid. So can we study ischemia with angio-OCT? In cases like this, we don't really need to, because it's evident from the color picture that this is a chronic ischemic case, and OCT angiography can only confirm what we already see from the color. Even in this case, we might guess that this is a non-ischemic case of CRVO. There are limited hemorrhages in 3 quadrants, visual acuity 0.4 decimal, and there is no relative afferent pupillary defect, so probably not ischemic. And with angio-OCT, we confirm our hypothesis. We used to struggle to know about ischemia using functional and anatomical signs, which were not so sensitive. And now we have all this imaging. And judging this image, would you vote for ischemic or non-ischemic? We have no time to hear your answer, but we have heavy hemorrhages in 4 quadrants, soft exudate, vision is 2200. We have a relative afferent pupillary defect, so we would vote for ischemic. Infrared is of no use, nor autofluorescence, the blue and the green. And with wide field angio-OCT, we surprisingly see there is no sign of ischemia. In one click, we have the answer. The main problem in this case is a CME that is resolved just with 1 injection of anti-VEGF. 1 month later, you can see no edema, no vascular dilation. Even the hemorrhages are gone from the comparison with the color picture. This is a different case of a 47-year-old woman. This is the good eye with the normal angio-OCT. In the other eye, she has a CRVO partially treated. We can see ghost vessels in the temporal and nasal quadrant. So we might think that she has some degree of ischemia. Vision is 0.3. And the central OCT is not so bad if we judge the external retina. So why only 0.3 decimal vision? The angio-OCT gives us the answer. Even more, the wide field angio-OCT showing the extreme thinning in the temporal quadrant. But I think the most striking answer is given by this picture that offers us the real extension of the ischemic areas. And we can superimpose the images to have a better idea of the latitude of the problem. In this 55-year-old male, we had this problem of very precise recurrent CME, precise like a clock. 8 weeks after each injection, he had a recurrence. So we thought about peripheral ischemia. The central OCTA basically told us that there was no ischemia, but not even the wide field OCTA. It was only the ultra-wide field image of OCTA that told that there was significant ischemia in every quadrant, but only in the very far periphery. So we knew we have to move on with the PRP, and you can see here the partial PRP already done. On the NFAS on your right, you see the signs of the PRP laser. This patient was studied in the iris with OCTA. We are looking into the study of the iris vascularization as well. So this 92-year-old woman was affected by late-stage AMD, and she came one day telling us that she had a drop in vision in the left eye, but the color pictures that told us that she had AMD. But she passed from 2200 to hand motion, and it was the OCTA that gave us the answer. This is the OCTA of the right eye, and this is the OCTA of the left eye, the one with drop in vision. So we can see there is no circulation in the retina. She had a central artery occlusion, and that was the reason for vision drop. Can we also study leakage with angio-OCT? Well, in cases like this, we don't really need to study leakage. We know the management just from the color picture, and the OCTA can only confirm our choices. But in cases like this, color and OCT were not so helpful. She was 20/20 at the time with barely visible CME, but with angio-OCT wide field, I could see ischemia and new vessels, so I advised for injection and PRP. And surprisingly, only 9 months later, she was partially lost to follow up. She had a very, she came back with a very severe situation, huge ischemia and extensive neovascularization everywhere. So in leakage is helpful to tell us whether we are looking at a neovascularization or shunts. Look at this branch vein occlusion. From the OCTA only, we don't know whether they are new vessels or shunt, but if we combine B-scan with OCTA, we look at the level of the abnormalous vessels, so we know which are new vessels and which are shunts, and we know the management. So we can indirectly study the effect of the leakage. Very challenging is the study of the choroid, more than the retina with the angio-OCT. I focus my attention on autologous choroidal transplant and choroidal tumors. So this is a case of choroidal transplant that I operated 12 years ago. She still retained 0.5 decimal vision. You can see in the B scan the patch of choroid in the macular area. Fluorescein and ICG are telling us about the vascularization of the patch, but then again, I can see the same result in the OCTA. This is the wide field OCT, although the vascularization of the patch is offered by the central OCTA. From the peripheral OCTA, I know that the peripheral vascularization is appropriate. And even in this case of high myopia, I want to show you this image because you were asking about high myopia and segmentation. This case has a very huge, deep staphyloma, but as you can see, you can obtain a good OCTA telling you about the vascularization of the patch, the atrophic area nasal to the papilla, and the vascularization on the harvesting site, on the temporal side where you have bare sclera and just retina on top. So yes, we can have all the information we need from OCTA. In tumors, I know it is crucial to reach a good differential diagnosis with a long list of different parameters for multimodal imaging. But if you look at cases like this, you can see that the amount of information offered by wide field technology. This patient came 20/20 vision, asymptomatic for just regular checkup. I found that lesion, and I studied that with autofluorescence, SLO, and wide field OCT, which is showing subretinal fluid. I knew the diagnosis just by looking at these images. Of course, she underwent fluorescein angiography, ICG, ultrasound, but I think most of you could guess the diagnosis just from this list of imaging. This is pre and post proton beam radiation. This is a very similar lesion, but when we go to we can see the subretinal fluid sign from autofluorescence, SLO. When we go to wide field OCT, we see fluid in the macula, intra and subretinally, and fluid on the retina on top of the lesion. And the wide field OCTA is different. We don't see anomalous vessels. We actually see dilated choroidal vessels, which are more silent than the previous case. This is the ENFAS showing the intraretinal fluid. So a diagnosis of benign congenital angioma was done. She was treated with PDT, and this is pre and post treatment. This is just a list of very peculiar choroidal lesion. My message is that I think with improvement in wide field technology, we might avoid more invasive techniques. And so I want to conclude with this beautiful OCTA of the choroid showing you the vortex vein and all the choroidal circulation. Thank you.
Oh, that was a superbly wonderful talk, Doctor. I mean, I'm so glad I was here today to hear you talk.
Thank you so much.
Thank you. Thank you very much. Dr. Srinivas?
Yeah, Dr. Barbera, a fantastic talk. And I've seen your videos in the APAO and APVRS as well. Very beautiful. So my question still remains on this choroidal autologous transplants, the choroidal RP. And you have shown a beautiful videos of getting the vascularization reset back again. But still, what about the visual acuity in these kind of cases? And why do we not see much of visual improvement? Though we see, I was really amazed to see that video, how nicely it has got integrated. And so nicely you can see that it's got interconnected and it's totally vascularized as
on purpose. Thank you so much. On purpose, I selected a very old case, 12 years of follow-up, still retaining 0.5 vision is not so bad, 0.5 decimal, not so bad. So half of the patient can reach reading vision, and the improvement in average is 2 lines of visual acuity compares with baseline. And I found out that is totally about case selection, as often happens in our surgery. So this surgery works only if the external retina is still present preoperatively. Otherwise, it doesn't work, and you will not have any functional improvement if you are operating patient without photoreceptors and with late-stage disease. So this is the pros and cons of this surgery. You have to operate cases which are not end-stage. And these are usually the patients that are operated. That's why colleagues think that the surgery doesn't work, but that's not true.
Dr. Jay, one word before we go on to our last speaker.
Fantastic presentation. I don't want to spend time in praising how well it was. Just a quick question, Barb, that did you see any choriocapillaries on your OCT angio post-surgery? Because the large vessels can be there because they were already there. But I would be really interested to see that by putting the choroid graft, did you get chance to actually image the choriocapillaries in that area? But that is going to define the visual acuity improvement.
Yeah, you can go through the whole layers as you do in normal study of the choroid. When you do the segmentation, you can find the whole layer. What I'm transplanting is a full thickness patch. So what's left in the harvesting size, bare sclera, you transplant the whole thing. So it must be there, otherwise it doesn't work.
Very interesting. Thank you.
Jay, which machine is this? Is this Plexilate?
Must be Plexilate, right, Barbara?
Must be.
Plexilate.
Which machine is this?
It's so the machine was OCT, the Canon Xefilio, and and the S1, and the color picture are from Clarus Zeiss. Yeah.
Okay, thank you.
Canon, yes.
We shall now go on to our next speaker and last speaker, and we look forward to a great talk from you, Dr. Praveen. And she's a senior consultant at the Vitreoretinal Department at Shankar Nethralaya, Chennai. And she is going to tell us about correlation between OCT and multifocal ERG, the clinical applications. On to you, Dr. Praveen.
Thank you, Dr. Chitra, for the invitation. I'll just start with my So after a very good talk by Dr. Barbara, I think I'm going on to a very niche topic, which I'm not sure how many would really find it very interesting. I'll try to keep it as interesting as possible. So this is how do we correlate the OCTA, which we have heard about the whole evening, and correlate it with multifocal ERG. So why are we interested in correlating these two investigations? What is the similarity? So both of them are non-invasive. OCTA also allows the depth resolved images of retina, and the MFERG is also giving us the functional dissection of the retina. Both of them are objective evaluation of the retina. Both are useful in the early stages of the disease and useful to assess progression of disease. Here is the difference where Oct gives us the structural analysis, whereas the ERG is giving us the functional analysis. The major application of comparison of OCTA with MFERG has been in diabetic retinopathy. And this has been an enigma, especially lately. A lot of discussion has been on this, that whether diabetic retinopathy is a microvascular disease or is it a neurodegenerative disease. So retina is definitely a part of the brain, and the word retina itself means a network. So only 5% of the retina is made up by the blood vessels. So if the diabetic retinopathy process was to involve the whole of retina, and if it was only involving the blood vessels, only 5% of the retina would be involved, which cannot be possible. So we are still, whether it is a microvasculopathy or is it a neurodegenerative disease, and if it is primarily a neurodegenerative disease, then it can be best assessed by a electrophysiological technique. The various electrophysiological techniques which are available to us, but we are going to talk more of multifocal ERG today. But before I go on to that, diabetic retinopathy can affect the full field ERG itself, and the scotopic responses are more affected. Implicit times can get prolonged, decrease in amplitudes are seen even on a full field ERG, even in cases with mild retinopathy. And increased IT and decreased amplitude of photopic 30 Hertz flicker responses also reflect that it is a cone dysfunction and not only the rod dysfunction. Rods are more affected than cones because of the high metabolic rate of rods, and hypoxia in the retina is most pronounced in the dark adapted state. So amazingly, few studies have come that if you sleep with lights on, you can actually reduce the hypoxic state and probably prevent diabetic retinopathy. So multifocal ERG, you can see that in normal subjects, these are the good normal responses. In patients without DR also, there is already a reduction in the responses. In diabetic patients with early DR, it's almost like a squiggle. And in diabetic retinopathy with late stages of disease, it is absolutely non-recordable. Especially in these areas which have the exudates and cotton wool spots, these can be particularly more depressed responses on multifocal ERG. And if it is edema, it depresses the responses even further. What happens on OCTA? In OCTA, the typical findings which are seen on DR include thinning of the RNFL or the GCC, and there is increased foveolae vascular zone. There is a decrease in the vessel density, both in the superficial and deep fluxes. And we have seen in the previous talks by the speakers on the quantitative analysis, and all these things can be assessed non-invasively. We did a study where we did try to compare the OCTA findings in patients with no diabetic retinopathy and compare them with the ERG. And we saw that definitely this vessel density in the superficial and deep fluxes was reduced, and this reduced progressively as the degree of severity of disease increased. You can see we did speak of the FAZ parameters. There is decrease in the increased size of the FAZ as well as increased irregularity and the circularity indices. All these can be hampered with the progression of disease. So a comparison of OCTA and ERG helps us to compare the morphological and the functional parameters. And we have seen that wherever there is a decrease in the vessel density, it corresponds with the B wave amplitudes. And this is a nice paper from Shankar Nethralaya again. And it shows that decrease in the vessel density as seen in the superficial and deep fluxes corresponded very well with the decrease in the responses on multifocal ERG, and this is the graph which shows the same. There has been a nice study, the Eurocondor study, which has looked at the functional and structural parameters, but they have also mentioned that it is not necessary that the microvascular lesions and MFERG always go hand in hand. In fact, they said that 61% of patients without visible microvascular changes could have neurodegenerative changes, and they said this could be a new neurodegenerative phenotype of diabetic retinopathy, while 32% did not have any abnormalities on MFERG, but had abnormalities on OCT, and this could be primarily a microangiopathic phenotype. So, as I did mention, multifocal ERG comes mostly from the outer retina, but it is the inner retinal ganglion cells which are supposed to be more sensitive to the damage by high glycosylated hemoglobin or glucose levels. There's another parameter called the photopic negative response, which can be even more susceptible to changes in the diabetes glucose levels, and this gives us a full field response. So this can be sometimes more sensitive. Going to some of the other diseases where these two can be relevant, one is retinitis pigmentosa, which again presents with a decrease in the superficial and deep capillary fluxes. And here again, the correlation has been seen with the parameters on multifocal ERG, especially the P1 amplitude in the ring 2. The parafoveal area has more significant loss and more associated with a decreased density of superficial and deep fluxes. This is an example. You can see this is a patient of retinitis pigmentosa, and the central area appears to be spared, which is why the patient still has good useful vision, and this can be very beautifully seen on an Optos picture on autofluorescence. And when we do the ERG, it shows it is almost completely extinguished. Multifocal ERG shows central island of vision which is preserved. You can see preservation of the ellipsoid on a structural B scan. On an OCTA, you can see superficial fluxes is reduced, vessel density, especially in the area which is just beyond the arcades, which corresponds to the area where there was reduced autofluorescence, and also deep fluxes shows a decreased vessel density. So there have been publications. They have also mentioned the same thing, that an enlargement of the FSZ and reduced vessel density corresponds to the area of reduced amplitudes on multifocal ERG. Similar thing in Stargardt's, we have decreased superficial and deep fluxes, vessel density, plus in addition to this, the choriocapillaris also shows a reduced density because of the reduced blood supply in the choriocapillaris, and we know these flow deficits in the CC in Stargardt's are much more than that what we see even in the AMD. So why is there a decrease in vessel density in inherited retinal diseases? And there have been two theories where they say that it could start with a vascular depletion, which causes RP degeneration. And because there is RP degeneration, there is modification of the VEGF concentration. And this then reduced demand because of the atrophy leads to reduced blood supply. But vice versa can also be true, that because of the reduced blood supply, because of which there is a reduced vessel density, and this is causing the RP degeneration. So there is more stress on the pathogenesis of disease, and we are understanding it better with our new imaging techniques. So this is helping us understand the disease in a much better way. And of course, Oct can help us rule out any underlying CNVM, which can be present in any of the inherited retinal disorders. You can see this is an example of Best disease, where the patient was actually received some anti-VEGF injections intravitreal outside, though this is a typical case of a Best vitelliform disorder. You can see on an OCT as well, but probably this is what was thought to be a CNV, but when you do a OCT angiography, you do not pick up any CNVM, and this is just a hypospace below the vitelliform lesion. And ERG, of course, puts the diagnosis in place with reduced EOG. In HCQ toxicity as well, which is not, which is an acquired form of disease, the reduced vessel density has been seen. And amazingly, they have divided these cases into two groups, where there is reduced multifocal responses as well as normal multifocal responses. And they have seen that the vessel density is remarkably reduced when there is abnormal multifocal ERG in patients with hydroxychloroquine toxicity. So even in the presence of a normal structural SD-OCT. So as you would know that SD-OCT actually forms one of the most important parameters where we have has been advised as a screening tool, but as OCT-A can even be more sensitive. This is an example of a patient who was on HCQ for a long time. You can see that though the vision is almost preserved, you can already see that multifocal responses are slightly less, especially in the central two rings. Ellipsoid is okay, SD-OCT almost looks all right. You don't have the inverted saucer-shaped sign. And here the OCTA, the vessel density almost looks fine. It is not too affected, but multifocal ERG has been able to pick up the reduced responses even early on. So in conclusion, it helps us to look at the functional as well as the structural changes and correlate them for better understanding and pathogenesis of disease. And of course, to rule out the presence of CNV in the IRDs. Thank you for the talk. And once again, thank you for the invitation and to participate in such a good discussion and topics. Thank you.
Thank you very much. That was a very crisp talk. And Dr. Jatinder, would you take a question?
Excellent last two talks, Dr. Barber and Dr. Parveen. Thank you so much. Very nicely put up. Dr. Parveen, just two questions. How often do you see choriocapillaries, loss of choriocapillary densities in macrodystrophies? Second, in occult macular dystrophy, do you have like evidence that there is choriocapillary ischemia? Because if even before the multifocal ERG affected, the prognostic follow-up of those patients.
So actually, in inherited retinal dystrophies, I would say functional aspect is definitely more important than you could pick it up structurally. And sometimes in presence of macular dystrophies, it will be difficult to evaluate the CCFDs or the capillary flow deficits because of the large amount of shadowing and scattering which we had. But we did assess CCFT interestingly in a very good paper which we have published recently also. It was that we had tried to look at CCFT in eyes, in the fellow eyes of PCV patients. And we found that the CCFD was increased even in the asymptomatic eyes when the other eye had PCV manifestations. So definitely there, I would say it can be of prognostic value, and probably it could show us that we need to follow up these patients well. But it is still a lot of work is going on. Probably Jay also would have done some work on it, and he would like to add something more to it.
Srinivas, you have anything to ask before we conclude?
No, madam, I think it's good to go. Thank you.
So I think I would like to
thank everyone.
Fantastic talks. Beautiful.
Each and every one of you have put up excellent efforts, great talks, right from Padmaja, Anand, Upsham, Dr. Divyansh, Pradeep. Thank you so much for putting up such a great show. Thank you.
This was a very wonderful session, and I truly have to thank my expert panel for being there right till the end. And such a great joy to see all of you here on the screen, and fantastic set of speakers. Thank you so much, each and every one of you, for making our IRC meeting such a star evening today. My very special thanks to Srinivas as always, and a lot of thanks to Jatinder too. And I do have to tell you that this Jatinder, I asked him to just put this program together, and I mean the topics, and I never thought for a moment that I would enjoy this so much as I did today. Thank you so much, Jatinder, for being there with us. My very special thanks to my ARC team, who are always there encouraging us to keep going forward. And again, our thanks are due to Kripal and Aios admin for all those SMSs which they send and their support in the background at all times. Thanks to Sai and Manjula from Numerotech for all those emails which bombard your inbox. And most importantly, I want to warmly welcome Mr. Sunil, who is the webinar admin. He was with us the first year, not in the second year. And I'm sure he'll bring in a lot more energy to all our webinars. Thank you very much, Mr. Sunil, for being there. I hope you're there. I think you are missing for a bit in between. Thank you again to all the delegates who have watched this meeting. And I'm sure if you have watched, you have learned a lot. Thank you very much, one and all of you. Thanks.
Thank you, Chitra, for a wonderful webinar. Thank you.
Thank you.
Thank you very much.
Thanks a lot.
Yeah.
Fantastic webinar. Thank you so much.
Thank you.